Am I audible?
Yes, sir, audible.
Okay. Hello everyone. Welcome to our today's session. First topic is adrenal insufficiency. A 50-year-old female post-op day 1 undergone right radical nephrectomy. She has developed hypotension, hyperkalemia, hyponatremia. She has a 6 month history of lethargy, black skin pigmentation, and weight loss. What may be the case? So adrenal insufficiency, it may be an indication of ICU admission, or also patients who are critically ill, they also develop adrenal insufficiency. It needs a keen eye to suspect and recognize this condition. Bearing this and unable to do, it may lead to catastrophic consequences. So cortisol is the major glucocorticoid hormone. It has a diurnal variation. Maximal release in the morning hours. Control of secretion is maintained by hypothalamo-pituitary adrenal axis. Each part has a negative feedback loop with the previous step. Cortisol is transported by cortisol binding globulin. What are the effects of cortisol? It increases the blood pressure. It causes gluconeogenesis, increases the glucose levels, lipolysis, insulin resistance, and immunosuppression. During stress and illnesses, the diurnal variation of cortisol is lost. So what are the types of adrenal insufficiency? It may be primary, secondary adrenal insufficiency, tertiary adrenal insufficiency, and relative adrenal insufficiency. 4 types. Primary adrenal insufficiency. It occurs when there is destruction of adrenal gland due to various causes. The most common cause is autoimmune destruction due to Addison's disease. There may be infection like tuberculosis, CMV virus, cytomegalovirus, histoplasmosis. They may also lead to adrenal gland damage. Some hemorrhages like Waterhouse-Friderichsen syndrome, antiphospholipid antibody syndrome, trauma to adrenal gland, they cause hemorrhages and lead to adrenal insufficiency. Some infiltrating diseases like tumors, amyloidosis cause damage to the adrenal gland. And some drugs like etomidate, even with a single dose, ketoconazole, rifampicin, they will cause inhibition of the adrenal hormone synthesis. So what is secondary adrenal insufficiency? It is mostly due to suppression of the hypothalamo-pituitary adrenal axis by exogenous steroid administration for a prolonged period. But abrupt cessation without tapering of the dose lead to this crisis. Who are the patients who are at risk? Those patients who take around more than 30 milligram per day of hydrocortisone for at least 3 weeks. If we stop abruptly in these patients, there will be crisis. What are the other causes of secondary adrenal insufficiency? One is pituitary tumor, one is Sheehan syndrome, that is pituitary ischemia, and any pituitary surgery leading to the gland damage. This is the most common type of adrenal insufficiency. In stress conditions, there is no increase in cortisol if the patient is suffering from this secondary adrenal insufficiency. Tertiary adrenal insufficiency. This is due to any defect in the hypothalamus that causes release of corticotropin releasing hormone. So it may be mostly due to exogenous steroid administration, any brain injury or stroke. Hypothalamus fails to stimulate the pituitary gland to secrete ACTH so that cortisol secretion is decreased. What are the symptoms of adrenal insufficiency? Patient present as fatigue, muscle weakness, weight loss, hyperpigmented skin, and in acute adrenal crisis, they may present as hypotension, hypoglycemia, hyponatremia, and fluid unresponsiveness. How to diagnose? Both primary and secondary adrenal insufficiency have low serum cortisol levels. But how to differentiate between these two conditions? There is a test called short synaptin test. So the baseline cortisol levels are first measured, then 250 microgram of post-syntropin, that is synthetic adenocorticotropic hormone, is given by IV or IM route. If the cortisol levels are measured after 30 minutes of giving ACTH. If there is no rise in cortisol levels, it is primary adrenal insufficiency because the adrenal gland is dysfunctional, so there will be no synthesis of cortisol. But the problem is, if the problem is in pituitary, there is rise in cortisol levels, and this is secondary adrenal insufficiency. Coming to the new thing, that is relative adrenal insufficiency, also called as critical illness related corticosteroid insufficiency. In critical ill patients, those patients who are on vasopressor for a prolonged period and on ventilator support for a prolonged period, they develop this relative adrenal insufficiency. Diagnosis of relative adrenal insufficiency is very difficult actually. It is a diagnosis of suspicion in critically ill patient who develop refractory unexplained hypotension. Random cortisol levels may be normal or low in these patients. Serum free cortisol assays may be helpful in this patient, but this free cortisol level assay, these are being not done in all the centers. So what is the treatment of adrenal insufficiency? As in any acute cases, ABC management is the most important thing. Then IV steroids. This is the cornerstone of the therapy. Hydrocortisone is given IV. Then general ICU care, as in all ICU patients. Then more very important thing is to taper the treatment according to the need of patient, and after recovery, followed by endocrinology consultation for a prolonged period of follow-up, so that patient does not develop repeat insufficiency. So this is a diagram showing relative adrenal insufficiency. So in patient with prolonged critical illness for several weeks, there is hypercortisolemia and high circulating bile acids and other endogenous glucocorticoid receptor ligands. And some modifiable risk factors are also present in these patients, like drugs that are commonly used in the ICU and they interfere with the hypothalamo-pituitary axis, like glucocorticoids and opioids. What they will do, they will stop, they will inhibit the hypothalamus, they will inhibit the pituitary. There is negative feedback loop inhibition leading to sustained negative feedback inhibition and hypothalamic pituitary levels, leading to loss of ACTH mediated stimulation of the adrenal cortex. There will be no release of cortisol. And some drugs also are there. They can directly inhibit the adrenal gland, like opioids, etomidate, ketoconazole, rifampicin, phenytoin. They will lead to critical illness related corticosteroid insufficiency. What are the symptoms? Decline in the plasma free cortisol levels with normal to low plasma level of ACTH. Then some unexplained encephalopathy may develop. These patients have delirium, they have fatigue, and continued unexplained need of vasopressors. Electrolyte disturbances like hyponatremia, hypercalcemia may be there, and new onset eosinophilia may be found in the complete blood count. So if we find these type of patients, we have to treat this patient immediately. The treatment of SIRCI have improved mortality in very few studies actually. Most of the studies have shown decrease in the vasopressor requirement and duration of the ventilation requirement. But the decrease in dose of the vasopressors does not always mean that the patient is steroid deficient, because uh, if we supplement the steroids from outside, they reduce the cytokine levels. That may lead to decrease in the vasoplegia. So blood pressures may improve. So this is a flow chart showing various kind of critical ill patients coming with adrenal insufficiency or adrenal crisis. One is history. By history, you have to know which spectrum this patient is in. Pre-existing intrinsic disease, hypothalamo-pituitary axis disease, acutely triggered by any stress event like infection, surgery. This is acute adrenal crisis. This may be primary adrenal insufficiency or secondary adrenal insufficiency. While evaluation, you can see if there is cortisol levels decrease and ACTH levels is increased, this is primary adrenal insufficiency. If the cortisol level is decreased and ACTH levels are also decreased, then it is higher center, that is pituitary problem, secondary adrenal insufficiency. What is the treatment? You have to treat with hydrocortisone, as I told, 100 milligram bolus followed by 200 milligram IV for 24 hours. If there is improvement, you can decrease the dose gradually. Day 2, 100 milligram IV in 24 hours. Day 3 to last day of ICU, 60 milligram of IV for 24 hours. And thereafter, taper to maintenance dose and discharge, follow up with endocrinologist. And most of the patients, In ICU, they develop shock like septic shock due to infection. They're not responding to IV fluids and vasopressors. This is refractory shock. There is no need to do any ACTH stimulation test as it is flawed. So directly you can give a trial of hydrocortisone, 200 milligram IV over 24 hours, continuous infusion. These are called pharmacological doses. If there is no hemodynamic or respiratory response, then you have to stop. But if there is response, you can continue up to 5 to 7 days and then you can stop immediately. And in prolonged critically ill patients requiring mechanical or pharmacological vital organ support for several weeks with symptoms and signs compatible with adrenal insufficiency, that is critical illness related insufficiency, you have to evaluate clinically this non-specific signs and symptoms, as I told from in the previous slide. Currently, there is no established or validated diagnostic test, although absence of increase in the plasma ACTH and cortisol levels is suggestive. How to treat? Consider hydrocortisone 60 milligram IV 24 hours, as it is a physiological dose. Bolus dose of 40 milligram in the morning and 20 milligram in the evening. You have to continue it as it is a substitution dose during critical illness. Taper the dose of hydrocortisone as soon as possible after clinical improvement. And tapering schemes, these are not actually properly known, but you have to discharge the patient once he is clinical stable, and you have to keep him with endocrinology follow. So before completing, you have to know the side effect of steroids. Hypothalamo-pituitary axis suppression, hyperglycemia, delirium, myopathy, impaired wound healing, immunosuppression. And take home message from this class is no need to do any cosintrophin test, ACT stimulation test. You can directly give steroid hydrocortisone dose and see the response. If there is response, definitely the patient is going to improve. But the improvement is not in terms of mortality, only in terms of decreasing of the vasopressor dose and dependency of the ventilator. Anyone having any doubt from yesterday's classes, you can keep it in the chat box so that we can discuss later.
Avinash, yours is over.
Yeah, mine is over.
You start.
My slides are visible.
Yes.
Okay. Hello everyone. So today now I'm going to teach you about thyroid emergencies. So directly going into the topic. We have short time. So 68-year-old lady, known case of Graves on antithyroids, operated for lap coli 4 hours back and was in ward. Patient developed fever, tachycardia, heart rate of 180 per minute. ECG showed atrial fibrillation and patient developed shortness of breath. So what are the differential diagnoses for this case? Anyone would like to type the answers? Is anybody typing any answers differential for this case?
Yes, sir. Sir, actually the patient is not prepared properly before OT. Suppression must be done to avoid thyroid storm.
Okay, so your provisional diagnosis is thyroid storm. Very good. Any other differentials? See, whenever you are asked differentials, don't always keep your focus on the particular topic like thyroid. Okay. Again, run your imaginations. Yeah. Okay. Tell all the differentials for tachycardia. Tell all the differentials for fever. Tell all the differentials for SOB. Okay. Those are all differentials. Don't only think about thyroid. Thyroid. Okay. It is. We know the topic is thyroid today. Patient is Graves on antithyroids. So thyroid storm is definitely the provisional diagnosis. What are the differentials? So tell me, what can cause fever? Post-op patient was operated 4 hours back. What can cause the fever? So that will be a differential. Sepsis can be a cause. Sepsis, tachycardia. So tachycardia can happen. Post-op tachycardia. AMI can happen. Then your lap poly, mostly it was done in general anesthesia, under general anesthesia. So patient developing SOB and tachycardia can be respiratory distress, weaning failure, improper reversal. Okay. So fever means the fever is there. So sepsis can also be a differential. Okay. So these are the differentials: AMI and your improper reversal. So what are the etiology of thyroid storm and how to diagnose thyroid storm? So most cases of thyroid storm, they are caused by because of some triggering condition, okay, in conjunction with the underlying thyroid cause. So these are the causes. So here the trigger was a OT operation, okay. The patient underwent a surgery, lap chole. So that was the trigger that caused the thyroid storm, okay. So medical precipitants, thyroidectomy, non-thyroid surgery. So this was the precipitant, and then radioiodine therapy, exposure to excess iodine, excess thyroid hormone injection that can also cause a thyroid storm. Drugs such as amiodarone, sorafenib, ipilimumab, whatever. Okay, so diagnosis is generally done by high level of suspicion. That can be for thyroid storm. There is means at such acute means condition we cannot go for a definitive diagnostic here. So it has to be high level of suspicion. Patient is a known case of hyperthyroid. Patient is on drugs. Patient on thyroid medications or something, or patient has the Graves disease or whatever. Patient has a hit that is called the trigger. That can be a sepsis, that can be fever, that can be a surgery, or all these which conditions I told, they can cause a thyroid storm. Okay. So diagnosis is done generally by the Buch-Schwarzschild point scale. Score has to be more than 45. Okay. So that is diagnostic of thyroid storm. There are other scores also developed by Japanese society, thyroid society. They have also developed a score of their own, but this is a widely accepted score. So these are the various scoring points. The points under tachycardia, congestive heart failure that causes that SOB, arterial fibrillation, precipitant history, temperature, fever, okay, CNS effects, mild, moderate, severe agitation, delirium, psychosis, seizure or coma, GI, moderate involvement like diarrhea and all, that is moderate, then severe if there is jaundice present. These are all the signs of thyroid storm. Okay, so this is your again the Japanese classification which I told. So presence of thyroid toxicity with elevated levels of prerequisite. This has to be there. Free T3 and free T4, high levels of free T3, T4. Symptoms like CNS manifestations, restless delirium, fever has to be present, tachycardia. This is the okay. Then there is the grade of thyroid storm 1 and 2. So management, coming to the management, basically here you have to go for a, again coming to management, it has to be always ABCDE. Patient is tachycardia, patient is SOB. So we generally may have to check the airway, breathing and circulation. We have to see the BP also. So for diagnostic, we have to send thyroid profile. LFT is for that according to that score which we saw, Buch score. Okay, so LFT has to be sent to see if there is liver involvement. Routine investigations, ECG, chest X-ray to see if there is failure. Okay, brain imaging to rule out. Patient is supposed delirious. We have to do a brain imaging to rule out organic causes. So aim of treatment, first it has to be supportive care, ABCDE. You have to control the heart rate, control the temperature. Okay, so supportive care, then we have to go for the inhibition of hormone synthesis. Okay, so basically we have to go first for supportive care, rate control, temperature control to stabilize the patient. So ABCD first, fluids has to be given as there will be insensible fluid loss. Patient is tachycardic. Okay, temperature because of fever, then temperature control has to be done. You can go, you can give drugs for temperature control. You can go for your cooling, external cooling, or you can go for IV cold saline. You can do bladder wash. You can do Ryle steam cold saline wash, tympanic membrane wash, cold saline, or your ice blankets. Okay, to come down on the temperature. You can keep ice packs in groin, ice in the armpits. Okay, the various temperature control mechanisms. Now coming to the drugs, so which inhibit hormone synthesis, antithyroid drugs. Either you can give methimazole, MMI, or PTU propylthyrosol. Okay, so IV methimazole in severely ill with impaired consciousness. PTU propylthyrosol is only oral, right? Only oral formulation is available. So if the patient is delirious and all, we can go for a IV methimazole. Okay, so mechanism action. The dose is propylthyrosol 600 milligram per day. It also inhibits type 1 dehydrogenase activity and peripheral organs. So first choice. Then methimazole can be given 60 milligram per day. Okay. So these are the side effects. Cholestyramine can be given. These are suppose there is thyrotoxicus factitia, that is patient popping up many thyroid drugs or pills at the same time, leading to thyroid storm. So cholestyramine is a binder, so that removes the from the GI tract. Inorganic iodide should be administered simultaneously with the antithyroid drugs. Okay. So what do the iodide do is the decrease thyroid hormone synthesis by inhibiting iodide oxidation. That is called the Wolff-Chaikoff effect. So we can also give saturated solution of potassium iodide or Lugol's iodine. So dose is 200 mg per day. Lithium can also be tried. Okay, after improvement, doses of inorganic iodide should be gradually reduced before antithyroid drugs are tapered. The thyroid hormone level should be closely monitored rather than the TSH levels. Now, steroids has to be given with hydrostom regardless of its origin. 300 mg per day. You can give a hydrocortisone 100 mg TDS, or you can give dexamethasone 8 mg per day. Okay, they prevent the peripheral conversion of T4 to T3. So there are other drugs also which prevent peripheral conversion of T4 to T3, like amiodarone and all. Steroids, amiodarone, beta agonists. Okay, so they prevent the peripheral conversion of T4 to T3. Those drugs can also be given. Now for the fever, as I told, aggressive cooling with acetaminophen, mechanical cooling with cooling blankets or ice packs. So because there is fever, as I told in the differential, focus of infection, patient had undergone surgery, that has to be also ruled out. You can find the focus of infection. Therapeutic plasmapheresis should be considered if clinical improvement is not noted in 24 to 48 hours. Okay. So what does the plasmapheresis do is it removes the excess catecholamines, cytokines, and TRAB. Okay. So replacement fluids with combination of plasmapheresis with continuous hemodiafiltration can be done. So it can be either done with FFP or can be done with albumin also. CNS symptoms you have to take care of. If there is seizure, you have to give anti-seizure drugs. If the GCS is low, you have to intubate the patient. Now coming to the tachycardia part, we have to control the heart rate. Otherwise, patient will go into diastolic failure. Okay, so tachycardia and the AF has to be controlled. So beta 1 selective, we have to give beta 1 receptor selective drugs first course of treatment. So these are the indications when to give what. Okay, Philip class less than equal to 3, heart rate more than 150, landiolol or osmolol should be selected as first course of treatment. If less than 150 beats, then can be changed to oral. If it has come down to less than 150, we can go for oral beta 1 selective, bisoprolol or whatever you use in your setup. So if the heart rate of the patient classified as Philip class 4, that is more than 150, then again landiolol or esmolol may be used. The heart rate should target heart rate should come down to less than 130 as earlier the possible, and discontinue the beta blockers if the heart rate goes below 80. So if there is persistent atrial fibrillation based on the chart score, we should go for anticoagulation. Okay, so that there is no LA clot formation. Then heart failure, we generally heart failure you treat by NIV or by intubation depending on the severity. You give Lasix to reduce the fluid overload. Once the rate control takes place, your failure generally will improve. Okay. So outcomes, mortality is a very dreaded complication in case of thyroid storm. Patient goes into multi-organ failure. So due to MODS, multi-organ failure, heart failure, respiratory failure, that arrhythmias can also lead to your cardiac arrest, DIC, hypoxic brain syndrome, and hepatic failure. These are the causes of mortality in case of thyroid storm. So prevention, it is better to prevent thyroid storm. So definitive treatment of grave disease, it should be on the proper control before we go for any surgery. Infections should be prevented. So grave disease radioiodine treatment should be given, or thyroidectomy should be done to prevent recurrence of thyroid storm. So this is a schematic flow diagram of how to do. Always assessment of ABCD first. Okay, then symptoms from multi-organ systems, possible to thyroid storm, that's 4. Then suspected TS, thyroid storm, so measure your thyroid levels, then go for the definitive treatment. Okay, so cooling blanket, as I've already told, this is a flow chart. For heart failure, what has to be done? For tachycardia, what has to be done? For CNS, for liver failure, and for the complications also, what has to be done? To secure venous access for treatment of high fever, dehydration and all, methimazole, propylthiouracil, potassium iodide, Lugol's iodine, hydrocortisone, these are the treatment. This is the flow chart. Okay. Now, ICU admission is definitely necessary because multi-organ involvement takes place generally very quickly in case of thyroid storm. So, life-threatening shock, DIC, multiple organ failure, these all can take place. So, it is better to admit in ICU. DIC risk is very high. So, for congestive heart failure, as I told, furosemide, nitric acid can be given if there is high BP or anything. Beta blocker for heart rate control. Calcium channel blocker can be given if your ejection fraction is more than 40, 45. Plasmapheresis can be done to remove the circulating catecholamines. And in worst case, we may need heart-lung machine or ECMO before the development of multiple organ failure. Okay. So now coming to another case. Any doubts in thyroid storm and its management, you can write in the chat box. Okay, I will answer there. Now coming to a second case, 66-year-old woman presented to the emergency department after being found unconscious in her home. She lived alone and had no contact with the healthcare system for the past 20 years. On presentation, temperature of 31.2 degree or 88.2 degree Fahrenheit, heart rate of 46 beats per minute, BP of 109 by 64 millimeters of mercury. On examination, she had thin and brittle hair, loss of the lateral third of her eyebrows, macroglossia, and Duffy periorbital edema. So what next? So next we have to manage again, as patient is hypothermic, heart rate of 46, 109, patient was unconscious at her home. So again ABCDE, airway, breathing, circulation, we have to go for intubation of this patient. Okay, and because the patient is hypothermic, we have to go for gradual rewarming and not sudden rewarming. Patient has to be put on mechanical ventilation, fluids has to be given. Okay, so mostly what do you think in examination, what will you find? So this is a case of what? Mostly it is a case of hypothyroid, mixed edema coma. Okay, hypothermia, low pulse rate, patient is cold and calming. So mostly it is a case of hypothyroid, mixed edema coma, hypothyroid crisis. So what investigation should you like to send? And in examination, what will find? So your routine investigations, you have to send everything. And again, there has to be a trigger that can be sepsis. But as patient is in mixed edema coma, there will be no elevated temperature levels. There will be no fever. So we have to keep sepsis in mind also. Always for thyroid, any emergency, there has to be a trigger factor. Most of the times it is sepsis, or maybe some surgery, or maybe some drugs. So we send a thyroid profile, and the TSH level was found to be 131.6. Okay. So three key features of mixed edema coma is altered mental status. So it starts with somnolence and lethargy. Generally it takes months, and then the patient generally becomes stupor and comatose. Okay. So there is defective thermoregulation, hypothermia, lower the temperature, worse the prognosis. Okay. Mostly during winter months, fever may be absent, as I told, and the precipitating event. So three key features are altered mental status, hypothermia, and a precipitating event. Like look for cold exposure, infection, drugs like diuretics, tranquilizers, sedatives, analgesics, any trauma, stroke, heart failure, GI bleeding. Okay, these are all precipitating events. So typically a patient is an older woman with altered consciousness presenting in winter time. There is often a history of hypothyroidism present, or an neck surgery or radioactive iodine treatment. Now, physical examination, generally what we will find is hypothermia, hypoventilation, hypotension, bradycardia, dry coarse skin, macroglossia, delayed deep tendon reflexes. So, absence of mild diastolic hypertension, warning sign of impending mixed edema coma. And there will be generally non-pitting edema in this case. Okay, Generally, we see pitting edema in CKD, nephrotic syndrome, heart failure, but here generally we'll see non-pitting edema, puffy hands due to abnormal deposit of mucin in skin tissues because of the mucin in skin tissues. So non-pitting edema. Now, laboratory examination, generally we will find macrocytic anemia, hyponatremia, hypoglycemia, hypercholesterolemia and hyperlipidemia, high serum creatine kinase concentrations, low serum FT4, free T4, and high serum TSH. Serum TSH may sometimes be low or normal, and there will be hypoxia and hypercapnia. These are the findings. So coming to the pathophysiology, how does it it is caused? So precipitating event disrupts the homeostasis, which is maintained in hypothyroid patient by a adaptation of the patient's body. So adaptations like chronic peripheral vasoconstriction, diastolic hypertension, diminished blood volume in an attempt to preserve a normal body core temperature. So once there is a trigger, this goes into disarray and patients develop mixed edema coma. So it will not the homeostasis will not be maintained if blood volume is all reduced any further, like GI bleeding or the use of diuretics. Patient goes into mixed edema coma. Intercurrent pulmonary infection, these are the triggers. Okay, CNS regulatory mechanisms gets impaired by stroke. This is again a trigger. Sedatives, hyponatremia, these all are triggers that cause the mixed edema coma. So decreased metabolic rate that results in neurological dysfunction, cardiovascular instability, and tissue edema. So classification of hypothyroidism, primary, most common is related to failure of thyroid gland to synthesize or secrete thyroid hormone. So Hashimoto thyroiditis is the most common cause of primary hypothyroidism. Secondary, there is failure of pituitary gland to secrete thyroid stimulating hormone. That is what causes the hypothyroidism. So here TSH levels will be low. So there can be a myxedema coma in case of secondary hypothyroid failure also, myxedema coma. So here the TSH levels will be normal. And tertiary, there is failure of hypothalamus to secrete thyrotropin releasing hormone. So this thyrotropin releasing hormone TRH, it acts on the pituitary to secrete TSH. So when there is hypothalamus fails to secrete TRH, so there is no stimulus for TSH secretion, and thus there is hypothyroidism. So the TSH levels are high only in primary hypothyroidism, that is the thyroid is unable to synthesize. So the signal keeps coming from the pituitary to secrete more and more. So the TSH levels are high. But in secondary and tertiary, there is no TSH only, low or normal. Okay. So coming to treatment, so we have to treat the hypothyroidism, we have to treat hypocortisolemia, we have to treat hypoventilation. As I told, intubation mechanism is already done for this patient. You have to treat the hypothermia, no active rewarming, gradual rewarming, okay, blankets only. So hyponatremia, mild fluid restriction. So hypotension, treat hypoglycemia, and treat the precipitating event. Liberal use of antibiotics, as the patient might be having a sepsis that triggered the mixed edema coma, but because of your patient is in hypothermia, there will be no signs of fever, so you cannot rely on the presence of fever as a cause of uh, infection that triggered the mixed edema coma. So what you have to give: thyroid drugs, thyroid supplements, levothyroxine 200 to 400 microgram IV loading dose, followed by 50 to 100 microgram per day. Okay, liothyronine plus, we have to give both. Okay, so liothyronine is the T3. Okay, the liothyronine 5 to 20 microgram IV loading dose, followed by 2.5 to 10 microgram Q 8 hourly or TDS. So you have to give both T4 and T3 supplement. Lower doses preferred in elderly patients with low BMI and patient at risk for MI or arrhythmia, because thyroid can cause your tachycardia and all, and can cause myocardial infarction, AMI. So we have to give lower doses in severe, very elderly patients. So therapy with T3, okay, is continued until there is clinical improvement. So do not stop T3 until there is clinical improvement. So typical oral levothyroxine dose is 1.7 microgram per kg per day. So that can go up to 100 microgram per day. So IV dose of levothyroxine is twice as potent compared with equivalent oral dose. Okay. So there should be prompt identification and treatment of the precipitating events. So this is how you will treat your mixed edema coma. Now hydrocortisone you have to give again in case of thyroid toxicosis also. Thyroid storm, here also we have to give 100 mg IV Q8 hourly until you rule out adrenal insufficiency. Okay. So pituitary adrenal function is impaired in severe hypothyroidism. So exogenous thyroid hormones may precipitate adrenal insufficiency. So it is prudent to administer glucocorticoid in stress doses, that is 100 mg every 8 hours. So mechanical ventilation, as I told, the cutaneous blood flow is markedly reduced. So in order to conserve the body heat, warming blankets will defeat the mechanism. So the central warming may not be may be attended, but peripheral warming should not, since it may lead to vasodilation and shock. So passive rewarming is preferred over active due to risk for vasodilation and hypotension that can cause shock. So fluid restriction has to be done, and because the patient is in like a fluid overload, there is edema and everywhere. Isotonic sodium chloride usually restores the normal sodium. If there is severe symptomatic hyponatremia, then you may go for 3 NS. Vaptans may be useful. Conivaptan or tolvaptan may be useful in hyponatremia, as high vasopressin levels are generally observed in myxedema coma. Volume expansion is usually required in case of hypotension, okay, because they are vasoconstricted. Vasopressors may be added. Serum glucose should be monitored, because again low sugars and all can cause precipitate your myxedema coma. So supplemental glucose. So signs of infection will be absent. So prophylactic antibiotics should be provided to the patient until infection is ruled out. Okay, so even if there is no fever, tachycardia, leukocytosis, you have to go for antibiotics in patients of myxedema coma. Now follow up in case treatment. In case the treatment was initiated with IV T4, but after 24 hours the patient is still comatose, then IV administration of T3 should be considered. Now T3 should be discontinued, replaced by T4 once circulation and respiration have been stabilized. So when the patient is awake, we can come to your oral administration. We can go for oral thyroids, okay, instead of the intravenous thyroids. Thank you. Dr. Anjali, good answer. Malignant hyperthermia can be definitely a diagnosis. Subhadeep also, very good. Malignant hyperthermia can definitely be a differential diagnosis of thyroid storm. Okay, I forgot that one to say. Very good answer.
Thank you, Dr. Samir. The next presentation is by Dr. Rupali Patnaik on diabetic emergencies.
R also, R, who is someone that is R. Very good answers. Surgical stress leading to storm. Malignant hyperthermia due to anesthesia drugs. Very good. Good answers, everyone. Any doubts, please write in the chat box.
Yeah, should I start?
Start.
Yes. Very good afternoon, everybody. I'll be dealing with the topic diabetic emergencies. Diabetic emergencies are decay in HHS, that is hyperosmolar hyperglycemic state. They are the most serious complications of diabetes. They are called the diabetic emergencies. Decay is defined by the triad of hyperglycemia or a new diagnosis of diabetes, especially in cases of type 1 diabetes, and metabolic acidosis and ketonemia. These are the triad: hyperglycemia, acidosis, and ketonemia. But HSS is defined by severe hyperglycemia, where the hyperglycemia is much more intense than the decay case. They are associated with high serum osmolarity and dehydration. Coming to epidemiology, decay is characteristically associated with type 1 diabetes and in type 2 diabetes patients under conditions of extreme stress. Decay more common in young patients, that is less than 65 years of age, whereas hyperosmolar hyperglycemic state is more commonly developed in individuals older than 65 years. The rate of hospital admission for HHS is lower than that of the decay and accounts for less than 1% of all primary diabetic admissions. Mostly they admit with emergencies is decay. But the mortality rate for patients with HHS is between 10 to 20%, which is approximately 10 times that of the higher than that of the decay. Though clinical presentation in patients with HHS is less compared to decay, the mortality rate is quite high in patients with HHS. Coming to pathophysiology of these diabetic emergencies, decay and HHS both. Here in the left side is there is absolute insulin deficiency, which is most important in patients with type 1 diabetes mellitus. Their pancreas do not secrete insulin. The absolute insulin deficiency leads to increased lipolysis. That will lead to breakdown of free fatty acids, that increase free fatty acid production that will go to liver. In liver, there is ketogenesis. The free fatty acids, they are the substrates for ketone body production. This leads to increased ketogenesis. The amount of ketone body increase, this exceeds the alkali reserve of the body, and this leads to ketoacidosis, increase in ketoacids. And also free fatty acids, they lead to production of triacyl glycerol, which is one of the component of free fatty acids, and that itself lead to hyperlipidemia. What happens there in diabetes also? There is increase in counter-regulatory hormones. These counter-regulatory hormones, which opposes insulin, this leads to increased proteolysis, that is protein breakdown and decreased protein synthesis. There is decrease in synthesis and increase in breakdown of proteins, leads to increased gluconeogenic substrates. Thus, these products lead to substrates for gluconeogenesis, that is increased glucose production and increased gluconeogenesis. Okay. Decreased glucose utilization and increased glucose production and increased glycogenolysis. This is the main three things. Three is decreased glucose utilization, increased glucose production, and increased glycogenolysis. That is, glycogen is lysis leading to glucose production. Okay, all these lead to hyperglycemia. These hyperglycemia, which leads to glycosuria. Glycosuria, increased glucose excretion there in the kidneys, and this leads to osmotic diuresis. That is, along with glucose, there is obviously loss of water and electrolytes. This loss of water and electrolytes leads to dehydration. That is, decreased fluid intake in the along with the dehydration associated with decreased fluid intake. This leads to hyperosmolality. Obviously, there is loss of glucose. Along with that, there is loss of water. This leads to dehydration. Along with that, patients with altered sensorium. This is especially important in patients with HSS. The old age patient, they are unable to compensate that, which increasing the intake of the fluid. Obviously, there will be hyperosmolality. Okay, and this dehydration obviously and glycosuria will lead to impaired renal function. Okay, this characteristic of HHS is hyperglycemia, impaired renal function. Obviously, impaired renal function there in the decay also, and relative insulin deficiency, especially in the type 2 diabetes. Okay, there is lead to all these three things: the decreased glucose utilization, increased glycogenolysis, and increased gluconeogenic substances. This leads to hyperglycemia. But there is obviously, due to relative insulin deficiency, absence or minimal ketogenesis. That is, there is no ketoacidosis here. There is minimal ketoacidosis, but other things like hyperosmolarity and dehydration that oversees the decay cases. What are the predisposing factors? Obviously, predisposing factors for decay is new onset diabetes, like in type 1 diabetes, inadequate insulin treatment or non-compliant. That is most important. Patients are not being compliant with the insulin regimen, and they are missing most of the therapies that lead to inadequate treatment and non-compliance for the important cause of decay. Then most important is the acute illness. Acute illness can be infection. Infection, most important is the pneumonia and the urinary tract infection. This is like cerebrovascular accident, CVA, myocardial infarction, or acute pancreatitis. These are important causes of acute illness which precipitates decay in patients with diabetes. And also associated drugs. Drugs can be like antipsychotic drugs, cocaine, lithium, SGLT2 inhibitors, okay, the gliptins. They are the main culprits for causing the decay, basically. Like HHS. HHS is also infection, pneumonia, UTI, and sepsis at all. The infection, pulmonary embolism, any acute stress, and the acute illness, sepsis, all these conditions will precipitate the HHS. Various endocrine causes associated with that, like thyrotoxicosis, Cushing syndrome, any other and various drugs which precipitate this HSS in patients. Just to remember, is most important 5 I's. These are the predisposing factors for decay and HSS. These are infection, infarction, intoxication, ischemia, and insulin missed. Mnemonic is very much important to remember. These 5 I's are the precipitating factors for these diabetic emergencies. Then coming to clinical features of decay. Decay presents with polyuria, polydipsia, abdominal pain due to precipitating cause itself, or it can be metabolic acidosis. Okay, nausea, vomiting, Kussmaul respiration, that is respiratory compensation, gasping respiratory pattern, acidotic breathing is the Kussmaul respiration. Then fruity odor of the breath, the presence of acetone in their breath. The mucous membrane is dry, the patients are tachycardic and hypotension. Obviously, there is dehydration. Then HHS, or nowadays it is called as hyperosmolar hyperoncotic non-ketotic state. This is their clinical presentation. It is more insidious than decay. Decay is like acute presentation, but it is like over the days they are these patients are ill and they present this insidiously. The older patients, less they are concerned about this illness, and usually they present with days of polyuria, polydipsia, severe dehydration, and most notably the altered mental status. Most common in older patients and people with type 2 diabetes who usually have enough circulating insulin to prevent lipolysis and thus the ketone body production and ketoacidosis, as I have described there in the pathophysiology. It is characterized by significant hyperglycemia in absence of ketosis with hyperosmolality and mental status change, which is characteristic presentation of the HHS. And the same precipitating factor says decay, as I told, 5 I's to remember. Coming to lab findings for decay. Hyperglycemia, obviously, typically it is more than 250 milligram per dl, but decay can occur in patients with type 1 diabetes with relative normal glucose level even, because their insulin not at all being produced, that lead to increased ketone body production. Then elevated serum ketones, direct assay of beta hydroxybutyrate, which is the blood ketone, is better measurement for degree of ketosis than serum ketones. Okay. High enangiopathic metabolic acidosis. Okay, one of the most important cause of high enangiopathic metabolic acidosis is diabetic ketoacidosis. Here the bicarbonate levels may be normal or high in patients with vomiting, diuretic use, or alkali ingestion. It's important to remember. Obviously, there in decay there is less bicarbonate, but these factors are predominant. Like patient presented with high amount of vomiting, there is concomitant use of diuretics or any alkali ingestion. This bicarbonate may be normal. The hyponatremia and pseudo-hyponatremia. Obviously, with increase in glucose, the sodium is less. So we have to measure the corrected sodium. Corrected sodium is obviously measured sodium plus 1.6 multiplied by serum is 100 increase in serum glucose over 100. There will be 1.6 time increase in sodium. The corrected sodium is more. In correction of 2.4 is the factor when the serum glucose is more than 400 milligram per gram. The hyponatremia here it present is the pseudo hyponatremia because of hyperglycememia. Then we have to always measure this corrected sodium and think according to it. Initially normocalemic or hyperkalemic these patients, but once the insulin therapy is set in, they subsequently cause profound hypokalemia due to intracellular shift. Obviously, insulin causes intracellular shift of potassium that lead to profound hypokalemia with starting of the insulin therapy. Hypophosphatemia may develop with insulin therapy because of intracellular shift. There will be leukocytosis, hyperlipidemia due to lipolysis, and acute kidney injury due to volume depletion. The characteristic lab findings of HHS, there is severe hyperglycemia, even more than 500 milligram per dl, elevated plasma osmolality, typically more than 320 milliosmoles per kg. Calculated osmolality, we have to calculate. It is as per formula, 2 multiplied by sodium, glucose by 18, BUN by 2.8 in milligram per dl. Or it is like everything is millimoles, then we don't have this denominator factor. Then we have to measure the calculated serum osmolality always for accurate measurement. And electrolyte abnormality, similar to decay with regards to other electrolyte, especially most importantly the potassium and phosphorus deficits. These are less severe compared to the decay. And obviously there is hyperlipidemia, but there is absence of ketoacidosis. Coming to diagnostic evaluation, obviously these are medical emergencies. We have to initially evaluate, as in any case, is the airway, breathing and circulation status of the patient, the mental status of the patient, the airway, threatened airway, anything patient is obturned, we have to intubate and initially mechanically ventilate and stabilize the hemodynamics. Then we'll think for the possible precipitating factors and hit accordingly. That is the source of infection, whether it could be due to UTI or it is due to pneumonia or any other. It can be pancreatitis, myocardial infarction, or patient with CB also. Okay, we have to assess the volume status. That is most important. And adequately replace the volume. Volume replacement is the key factor, which is the management for decay and HHS. Then to labs, we have to send various labs, important glucose, electrolytes, renal function, creatinine, complete blood count, urine ketone If available of the blood ketones, then it is better. Plasma osmolality, blood gas analysis, and ECG cultures we have to send accordingly the relevant source and HbA1c. Coming to diagnostic criteria for decay in adults, various guidelines have been proposed. ADA, American Diabetic Association, you can these guidelines, but most important of endocrinology guideline, but we usually follow the ADA guideline, last published in 2009, they are not yet come after that. So here is the diagnostic criteria for decay. Obviously, increase in hyperglycemia more than 250, acidosis, there is grading of acidosis, and bicarbonate concentration as per the severity, mild, moderate, and severe, anion gap, and beta hydroxybutyric, they're not yet incorporated still because it is not available everywhere. Urine ketone bodies is the urine dipstick test is positive. Okay. Then for HHS, obviously plasma glucose very high, 33 millimoles per liter. If multiplied by 18, it will be like more than 500 milligram per DL, the sugar levels. pH is obviously more than 7.3, not in the case in the decay, if it is less than 7.25 always. And bicarb concentration is more there in the decay. The first starts with less than 15, here it is usually more than 18. Then anion gap is obviously can be normal here, and urine nitroprusside test, blood beta hydroxybutyric is not there. Obviously important is the presentation of stupor or coma, and osmolality more than 320 millimoles per kg. Then some important differences between decay and HHS here, same as before from the ADA guideline 2009, the mild, moderate, and severity of the grading of the decay and how it differs from the HSS. Obviously, the pH, the bicarbonate levels, presence of mental status, and serum osmolality. These are the important things which differentiate decay from HHS. Then comes the other differentials for these diabetic emergencies. So obviously, it can be alcoholic or fasting ketoacidosis, high anion gap metabolic acidosis, other causes like mud piles, we remember, lactic acidosis, metformin, acetaminophen toxicity, methanol, ethyl alcohol poisoning, all that. The causes of other causes of high anion gap metabolic acidosis in metabolic encephalopathy. Coming to management part, restoration of intravascular volume, prevention and correction of electrolyte abnormality, correction of acidosis, and correction of hyperglycemia. These are the main goals while managing these patients with decay and HSS. Obviously, the therapy is most important. IV, fluid, insulin, and potassium. These three things, always to remember, fluid, insulin, and potassium, important for management of these diabetic emergencies. This is the management algorithm I've taken from the ADA guideline 2009. So various, it is like older one only. After that, many more things are coming up, especially for the type of fluid, okay, compared to other things. That's why controversial. Here they have always administering the sodium chloride and N/2, but we are using valence salt solution along with the sodium chloride, and rarely we are using hypertonic solutions like N/2 or D5. The IV fluid here is the determine the hydration status, severe hypovolemia, then we have to administer 0.9% sodium chloride here, at least 1 liter per hour. Obviously, there is almost 6 liter of fluid deficit in the decay. Okay, initial time we have to transpose almost 3 liter, then we'll continue like 200 ml per hour or 250 ml per hour of the either valence salt solution or the sodium as per the corrected sodium value, so that the fluid deficit is being recovered. Okay, initial 3 liter at least they need from the ED only whenever they come. Okay, then other like mild dehydration is same as like serum levels and everything is based on according to that we have to maintain the fluid status. That is, resuscitation is most important. This patient present with almost 6 liter of fluid deficit. Then comes the insulin therapy. Insulin is the IV route is the preferable. We give either 0.1 units per kg bolus followed by 0.1 units per kg per hour infusion, or start with infusion of 0.14 units per kg per hour of continuous infusion without giving the bolus. Okay. Our target sets like to serum glucose does not fall at least 10% of the fast hour. Then we have to increase the units per kg as bolus, then continue as previous rate. If it is not, like its target is to decrease 50 to 75 milligram per DL per hour of the glucose level. Okay. When serum glucose level reaches 200 milligram per deciliter, we have to reduce the insulin infusion to 0.02 to 0.05 units per kg per hour. By this rate, you have to decrease. Okay, so that there should not be any hypoglycemia. So decrease slowly with this rate. And once there is decrease in glucose level by less than 250 milligram per dl, then we have to think for dextrose containing fluids. Okay. If it is 150, then if it is less than 200 or 300 in HHS, then we have to think for dextrose containing fluids as the maintenance fluid we continue. Then comes to potassium replacement. Potassium replacement, if it most important is the range to maintain between 3.3 to 5.2. If it is less than 3.3, then this much severe hypokalemia, then it is advisable to hold the insulin, because insulin itself will cause intracellular shift of the potassium. Obviously, there will be very less potassium that will be detrimental. That's why if it is less than 3.3, then we have to stop insulin and replace potassium. Then we'll think for continuing the insulin. Then that much important is the potassium replacement, and it should go hand in hand. The potassium replacement, the higher target is the 5.2. We have to always maintain more than 4. Then some other things like bicarbonate and phosphate replacement, I'll tell. Bicarb replacement, obviously, it's a controversial topic in DK and HHS. If the pH is less than 6.9, then only the guidelines are recommending to replace with the bicarbonate, that is 100 millimoles over 1 hour. Then we repeat if this pH is still not increasing from 7.0. Otherwise, bicarbonate itself has very other detrimental effects on the patients. Okay. Phosphate, obviously, there will be hypophosphatemia. They are recommending that 20 to 30 millimoles of phosphate may be indicated in patients which are the candidates, like patients with cardiac dysfunction, anemia, respiratory depression, or phosphorus concentration less than 1 milligram per deciliter. These patients are the candidates for phosphate replacement. Phosphate replacement is not that much mandatory. Once there will be decrease in acidosis and decrease in ketoacidosis level, the phosphate will obviously be normalized. But these patients, they can tolerate the severe hypophosphatemia, that is obviously severe hypophosphatemia, and patients with these disorder, we have to think of phosphate replacement. Then comes bicarb replacement. Obviously, as I told, slow administration of 100 milliequivalent over 2 hours, considered when pH is less than 6.9. The bicarb replacement, obviously controversial. Routine treatment is ketone bodies decrease. There will be obviously adequate bicarbonate except in severely acidotic patient. So acidosis may cause impaired, we know that it causes impaired myocardial contractility, it leads to cerebral vasodilation, coma, all these. Still, there is no role of bicarb here. Why? Because it has been seen the bicarbonate therapy for decay offers no advantage in improving the cardiac or neurologic function or the rate of recovery of hyperglycemia or ketoacidosis. Even that it has been moreover seen that various deleterious effects have been reported, like increased risk of hypokalemia, there is decreased tissue oxygen uptake, cerebral edema, and development of paradoxical CNS acidosis with the bicarbonate therapy. Coming to monitoring, serum glucose should be initially measured every hour until it is stable, while serum electrolytes, B1, creatinine, and pH should be measured every 2 to 4 hours, depending on the disease severity and the clinical response. How we think that the diabetic decay has resolved? The resolution is blood glucose level less than 11 millimoles or less than 200 milligram per dl, plus any two of the following, like bicarb is more than or equal to 15, pH is increased by more than 7.3, and anion gap is decreased to less than 12. Then there is resolution. Then resolution of HHS is normal osmolarity and regain of the normal mental status. Then important is how to convert. Our patients are recovering, then how to convert to subcutaneous insulin. All patients need to be transitioned from IV to subcutaneous insulin after resolution of decay or HHS. Administering long-acting basal insulin with or without short or rapid-acting insulin is needed at least 2 hours before IV insulin infusion is stopped. You have to overlap with the IV insulin, the subcutaneous therapies. Patients previously treated with subcutaneous insulin can be restarted on the pre-admission insulin doses if they are determined to be appropriate. Otherwise, we have to rethink for this subcutaneous regimen. The weight-based subcutaneous regimen characterizes calculating total dose 0.5 to 0.7 units per kg per day and giving 50% of the total dose once daily, that is basal insulin, we will give the lantus, and dividing the other 50% of the doses between breakfast, lunch, and other, like before dinner. Patients who are critically ill or not able to tolerate feed, they require IV insulin or fluids. Okay. Once they recover, then only we have to transfer to subcutaneous regimen, and there should be overlapping of at least 2 hours. Coming to complications of this diabetic emergency, okay, cerebral edema, most commonly in young children and adolescents, they present with decay is the initial manifestation. New onset type 1 diabetes, they are being detected at first with presentation of decay, okay. They present with cerebral edema and new onset or intensifying headache, decline in level of consciousness, recurrent vomiting, incontinence, irritability, abnormal respiration, delayed rise in serum sodium with treatment, and evidence of cranial nerve dysfunction. These are the other factors which are associated with these patients. They are the detrimental factors. These patients present with cerebral edema. Obviously, the osmotherapies are being recommended, 3% NS and mannitol. And further neurologic deterioration, obviously airway, breathing, circulation stabilization, and further and other is the electrolyte, cerebral electrolyte abnormalities. Obviously, hypokalemia or hyperkalemia with therapies, hypoglycemia, non-anionic hyperchloremic metabolic acidosis also with the therapies. We give normal saline air load that will to normal and non-anionic metabolic acidosis. And the complications of it can be myocardial infarction, potential for pulmonary edema in patients with underlying CCF. We give lots of fluid here, rhabdomyolysis in patients present with more severe degree of dehydration that will include rhabdomyolysis also. Thank you. Any questions? Please put there in the chat box.
Thank you, Dr. Rupali. The next presentation is by Dr. Satyajit. Tumor lysis syndrome.
Good afternoon, everyone. This is visible?
Yes, visible.
Okay. So today we are going to discuss next about tumor lysis syndrome. Tumor lysis syndrome is one of the oncometabolite emergencies which results from cell lysis and warrants immediate intervention. The cause is most common due to secondary to the initiation of chemotherapy to chemosensitive hematologic malignancies. But few case reports also suggest that TLS can be noted spontaneously or secondary to steroid therapy also. And the most common malignancies associated with TLS are bucket lymphoma and acute lymphoblastic leukemia. Pathophysiology: the lysis of cancer cells releases intracellular contents which include electrolytes, inflammatory mediators like cytokines and DNA. Electrolytes like potassium and phosphate, they in turn bind to the extracellular calcium, causing hypocalcemia. And the released DNA further gets break down to purines by the action of DNA enzyme and eventually accumulated as uric acid. So this cell destruction results in release of intracellular contents, various purine derivatives and nucleic acids, leading to various metabolic abnormalities like hyperuricemia, hyperkalemia, hyperphosphatemia, and hypocalcemia. So this is a flowchart depicting the pathophysiology of tumor lysis syndrome. On starting chemotherapy agents, there occurs lysis of cancerous cells, releasing DNA, phosphate, potassium, and cytokines. Phosphate and potassium in turn bind to calcium. Also, they get accumulated, leading to hyperphosphatemia and hyperkalemia and hypocalcemia. And the release cytokines, they produce cytokine storm, bringing about inflammation and hypotension, ultimately leading to acute kidney failure. And the DNA gets breakdown to adenosine, guanosine, and in subsequent steps, ultimately they get converted to xanthine. From hyperxanthine to xanthine conversion requires an enzyme, xanthine oxidase, which is the site of action for allopurinol. Xanthine leads to uric acid, which gets accumulated because it fails to get excreted in the urine, leading to hyperuricemia. Now, what are the hematological malignancies that are associated with tumor lysis syndrome? This is chronic lymphocytic leukemia, Burkitt lymphoma, diffuse large B-cell lymphoma, acute lymphoblastic leukemia, and rarely seen in case of retroperitoneal sarcomas, Also highly treatment sensitive small cell carcinoma of the lungs. Another thing to remember here is bortezomib is a proteasome inhibitor used in the treatment of multiple myeloma, and reports are found to be associated with tumor lysis in patients with multiple myeloma. Now coming to classification. Chiro-Bishop classification is the most commonly used classification used for tumor lysis syndrome since 2004. Broadly, two types of parameters are used, and first reading is taken at the presentation, time of presentation, and next within 7 days. One is laboratory parameters, others are clinical parameters. Laboratory parameters include serum uric acid level, serum potassium level, phosphate level, and calcium level. Uric acid level more than 8 milligram per deciliter, or there is increase in 25% from baseline. Potassium level more than 6 milliequivalent per liter, or 25% increase. Phosphate level more than 4.5, or 25% increase. In calcium level less than 7, or 25% decrease from baseline. Clinical parameters include acute kidney injury as marked by serum creatinine value increasing more than 1.5 times from the baseline value, seizure, sudden death, cardiac arrhythmia. And the diagnosis to be confirmed among the laboratory parameters, two or more than two of the laboratory parameters should be met in 3 days within 7 days of initiation of chemotherapy. And for clinical parameters, along with the laboratory parameter, one or more of the clinical parameters should be present. Then also we can call it tumor lysis syndrome. Now, what are the risk factors? Two types of risk factors. One is intrinsic tumor-related factors. Others are patient-related factors. Tumor-related factors are high tumor cell proliferation rate, chemosensitivity to malignancy, large tumor burden manifested by bulky disease of tumor size more than 10 centimeter in diameter, TLC count more than 50,000, and pre-initiation of chemotherapy value of LDH elevated by more than 2 times from the upper limit, and bone marrow involvement. These are the risk factors, intrinsic risk factors. And patient-related factors that predispose to TLS include say pre-treatment hyperuricemia, means the patient already has hyperuricemia before
Hello everyone. So today I will be discussing on obstetric disorders in critical care. Basically, I will be focusing only on hypertensive disorders and a bit on the liver disorders in pregnancy.
Is it audible? Is the presentation audible?
Yes, audible.
Yes.
So this will be my flow of slides. So first I will tell a couple of slides on physiological changes in pregnancy. What are the hypertensive disorders in pregnancy and what are the liver disorders in pregnancy? So if you see physiological changes in pregnancy, these are the hemodynamic changes that happen during pregnancy. Cardiac output, this is term pregnancy, this is labor and delivery, and this is postpartum, and this is the physiological parameter that is shown on the left side. So if you see the cardiac output increases around 30 to 50% at the end of term at term pregnancy, which reaches maximum during labor, and around 50% is the amount of cardiac output that happens during labor, increase in the cardiac output. And similarly, the blood volume also increases by 30 to 50%. The heart rate also increases by 15 to 20 beats per minute during term pregnancy. Whereas the systemic vascular resistance is decreases during term pregnancy. and the oxygen consumption increases by 20%, and red blood cell mass increases by around 15 to 20%. So if you see here, most of the values which are there in the hemodynamics are increased during term pregnancy, except for the systemic vascular resistance, which is decreased during the term pregnancy. The respiratory changes in pregnancy. So on the left side we have a non-pregnant patient, and this is all the pulmonary function tests results which are there on this left side, and the pulmonary function test results on this right side are given in gravida at term. So basically this shows the difference between the two in terms of the respiratory changes. So if you see here, the total lung capacity is going to be almost the same. That is, in non-pregnant it is going to be 4,200, and in a pregnant patient it is going to be around 4,000. The other capacities and volumes which are there, if you see here, the expiratory reserve volume is going to reduce in term pregnancy, and it is also and the residual volume is also going to reduce in term pregnancy. So both these combined together is actually the functional residual capacity of the FRC, and that FRC is also going to reduce in term pregnancy. The vital capacity includes the inspiratory reserve volume, the tidal volume, and the expiratory reserve volume. The vital capacity remains the same during a non-pregnant patient and in a gravida at term, that is at 3,200 ml. But what you will see here is the tidal volume increases during term pregnancy, that is 450 to 600 ml. At the same time, the inspiratory reserve volume remains the same in term pregnancy, whereas the inspiratory capacity slightly increases during term pregnancy because of the increase in the tidal volume. The inspiratory capacity is basically the inspiratory reserve volume along with the tidal volume. So if you see here, mostly the expiratory volumes and the residual volumes and the functional residual capacity is what is decreasing in term pregnancy, whereas the tidal volume and the inspiratory capacity is what is increasing during term pregnancy. But there is no change in the vital capacity, and there is almost no change in the total lung capacity that happens during term pregnancy. So these are the hypertensive disorders of pregnancy according to the ACOG, or the American College of Obstetricians and Gynecologists guidelines. These are the 4 types of hypertensive disorders. One is the gestational hypertension, second is preeclampsia, third is eclampsia, and the fourth is chronic hypertension with superimposed preeclampsia. So what is gestational hypertension? It's simply systolic and diastolic blood pressure. Systolic blood pressure more than 140 or diastolic blood pressure more than 90 or both, which happens on at least 2 occasions in which the BP has been taken 4 hours apart. But most important point is that it should happen after 20th week of gestation. And this should happen in the background of a woman having previously normal blood pressure. And if this happens, then gestational hypertension is what is defined as this. But what additionally happens in preeclampsia is, with the same definition of gestational hypertension, you will need to have other high risk features which add to definition of preeclampsia. So the BP definition, the BP taking definition, the number of weeks of gestation and beyond, all this is the same for the definition of preeclampsia. But additionally, you need to have an additional essential features. And what are these additional essential features? So basically, you will have either proteinuria, and if there is proteinuria, well and good, so it is preeclampsia. But if you don't have proteinuria, then you will need to have these features to define it as preeclampsia. So these are basically showing you all the end organ dysfunction that happen in preeclampsia. These are the counts, the platelet counts which you need to have for defining thrombocytopenia. If your patient has got creatinine worsening, and this is renal insufficiency, if there is impaired liver function with elevated SGOTs and SGPTs, if you have severe epigastric or right upper quadrant pain, new onset headache, pulmonary edema, and visual disturbances. So all of this, if these features are there, even if proteinuria is absent, you can define it as preeclampsia. So eclampsia is basically having an episode of convulsion. So basically it has to be a new onset convulsive episode. And this convulsive episode doesn't need to be only a generalized clonic seizure. It can be tonic, it can be clonic, it can be a focal seizure or even multifocal seizure. So any of this. Or if there's no seizures which has been seen, if there's altered state of consciousness in the setting of preeclampsia, then also if other causes have been ruled out, then also you can call it as eclampsia. But this part of the definition has to be taken a little bit of pinch of salt, because there are several reasons why a patient might have altered state of consciousness. So that's why you'll have to rule out other causes of seizures and then define preeclampsia if the patient has got altered state of consciousness occurring in the setting of preeclampsia. What about chronic hypertension? So basically, it's very easy definition that there should be some pre-existing hypertension before pregnancy has started, or if the hypertension is developed after pregnancy has started, it should be happening before 20th week of pregnancy. So if you see gestational hypertension and preeclampsia, those are beyond after 20th week of pregnancy that the hypertension would have started, should start to define it as preeclampsia or gestational hypertension. But here it should be before 20th week of pregnancy or before the pregnancy has started. So you must remember that sometimes patients can have chronic hypertension, and then on top of that, preeclampsia can also be superimposed. So basically, patient will be hypertensive prior to 20th week, as well as developing features of preeclampsia after the 20th week of gestation as well. So that will be preeclampsia superimposed on chronic hypertension. So once the definitions are out, just to summarize what we told, if a patient has got hypertension, BP of more than 140/90, if the patient has got less than 20 weeks, it is called as hypotonic hypertension, or it can also be preeclampsia superimposed on chronic hypertension. If the patient has more than 20th weeks of gestation, you see for proteinuria. If there's no proteinuria, you call it as gestational hypertension, or if there is proteinuria, you call it as preeclampsia. So preeclampsia can also be defined by the fact that if there is no proteinuria, if there are severe features such as the ones which are mentioned here, then also you can call it as preeclampsia, which is basically having very high blood pressures of more than 160/110, acute kidney injury, elevated liver enzymes, thrombocytopenia, pulmonary edema, new onset headache, visual disturbances, seizures. So all of this is basically also under preeclampsia. And if you elaborate preeclampsia further, if you have seizures, as I told, it goes into eclampsia. And if you have elevated liver enzymes and thrombocytopenia along with some amount of hemolysis, then you can call it as HELP syndrome, or the definition of this is hemolysis, elevated liver enzymes, and low platelets. So this is a case of a 35-year-old female who presented with 30th weeks of gestation, and she's come with episode of GTCS since morning, and then she's got some altered level of consciousness. And the husband actually tells that she's been complaining of abdominal pain for 2 days and headache, which was not relieved with acetaminophen. So this is classically going towards features of preeclampsia and then proceeding towards eclampsia. On examination, BP is around 190/110, and there is some bilateral pedal edema as well, and chest crepitations or pulmonary indicative of pulmonary edema. And urine dipstick test also shows proteinuria, and LFT is also elevated with increased AST/ALT. And she's got urine output, which is also reducing in the last 24 hours. So if you see here, this is one patient who's actually an eclamptic patient and who's got a lot of features of severe preeclampsia as well in terms of end organ dysfunction. So this patient basically needs urgent ICU admission and stabilization. So what monitoring will be doing for these patients? You have to do repeated clinical assessment, do an ECG, check for whether your patient has not developed MI and developed arrhythmias because of pulmonary edema as well as patient being hypoxic because of that. Pulse oximetry is important, and you will have to do hourly urine monitoring as well. So these are the guidelines from the ACOG. And what about other monitoring? You have to do regular blood gas monitoring. You'll have to do intra-abdominal pressure monitoring as well during resuscitation, because there might be possibility of developing an AKI, which can be resolved by giving guarded fluids. Serum magnesium levels have to be maintained. And why is this important? Because the treatment of preeclampsia and seizures is basically giving magnesium, and you have to also look carefully for the fetus as well, and do continuous fetal heart rate monitoring. So if you just summarize what management that we do in terms of an eclamptic patient that is presented to us, you first do a diagnosis, which is based on the clinical features that I told you. If you've got good amount of multidisciplinary care, you continue treating in your hospital. If not, then you shift to a center which has got multidisciplinary care. This is extremely important because this is not just you taking care of a pregnant patient. You also have the neonate which is there, which is going to get delivered. So you need other branches of medicine as well, which need to be with you while managing this patient. So you do an initial management stabilization, and in that initial management stabilization, you go see for the airway or breathing, and try to maintain a saturation more than 95. You anticipate a difficult airway in this pregnant patient. You do circulation wise, you do left lateral tilt, you do blood grouping cross matching in case the patient goes for a delivery, urgent delivery, which secure good IV lines, insert Foley's catheters for urine monitoring. In terms of seizure control, it is extremely important that you start a magnesium infusion, magnesium loading dose followed by an infusion. So usually this is the dose that you will be asked in your exams, which is a loading dose of 4 to 6 gram over 15 minutes, and then followed by an infusion of 1 to 2 gram per hour, and you continue it for 24 hours post delivery or 24 hours from the last seizure occurrence. So this is the actual protocol that you have to give, how you have to give your magnesium levels. And what you have to monitor during giving is that you have to see whether there is adequate therapeutic range which is achieved or not. So which is around 4 to 7 milliequivalents per liter. So usually this is not the levels that we achieve in our normal ICU patients who have deficiency of magnesium. So this is much higher than that. So you have to be very careful that you don't produce any magnesium toxicity and go beyond 7 milliequivalents per liter. You also at the same time have to see that whether there is adequate urine output. And one of the first signs of seeing for magnesium toxicity is basically loss of the patellar reflex. And once you have that, you can clinically suspect magnesium toxicity, and also you'll have to monitor the GCS. So what about BP control? Basically, you try to target a BP of around 140 to 160 and diastolic blood pressures of around 90 to 110, systolics of 140 to 160. Vasodilators are basically the drugs of choice, and you'll have to use advanced hemodynamic monitors in case your patient is extremely hemodynamically unstable. And only switching to oral hypertensives, usually you do it once the acute phase is over. Don't try to juggle around with your oral hypertensives when the patient is sick in the initial few days of ICU stay. To avoid diuretics, it can worsen AKI because patients are inherently prone to AKI when they come with preeclampsia and eclampsia, and you do strict input and output charting. What other things that you have to keep in mind when you manage a preeclamptic and eclamptic patient? Basically, one dictum is that any patient who presents with seizures after 20th week of gestation has to be managed as an eclamptic patient unless she has been proven otherwise. BP criteria are not the only things that you have to see. You have to also note that if it's seizures beyond 20 weeks, it's most likely an eclamptic seizure which has come to you. And what about decision and delivery? Basically, it depends on several things, such as the severity of the preeclampsia, gestational age of the fetus, what's the maternal and the fetal condition. So you will need multidisciplinary care to decide on when to do the delivery. So what are the complications that can happen? It can be varied, and some of them are pulmonary edema, ARDS, acute renal failure, and you can sometimes actually patients I've seen a couple of patients who come with subcapsular hematomas and hepatic impairment as well. So that also you'll have to keep in mind. So just a bit on liver disorders in pregnancy. This is my last slide. So basically, if you see liver disorders in pregnancy, there are 4 types. That is, one is hyperemesis gravidarum, the other is HELP syndrome, the third is intrahepatic cholestasis of pregnancy, and acute fatty liver of pregnancy. I wanted to focus on the trimester and the lab studies which are there. The differential diagnosis and prognosis, I will not be going too much into it because that is beyond the scope of this lecture. So basically, if you see hyperemesis gravidarum, this is usually in the first trimester of pregnancy or in the early second trimester. This is the red part which shows when it happens. And basically lab studies, you will have the ALT levels which are slightly above normal, or sometimes they can also be normal. And usually it will be approx 500 or near about that. That is what happens in hyperemesis gravidarum. But bilirubin will be usually normal in hyperemesis gravidarum. What about HELP syndrome? I told you this is hemolysis, elevated liver enzymes, E and L, and liver and low platelets. So this is the combination of all these things. Remember, HELP syndrome is something which happens in the late second trimester or the third trimester. And one of the very key things about HELP is that it can also happen in the postpartum period as well. So that is also one of the periods you have to be vigilant whether the patient can develop a HELP syndrome. And what about AST ALT levels? The AST levels are more than 70. That's the definition, the Tennessee definition of the HELP syndrome, which says that AST levels have to be more than 70. And if there's infarction that has happened in the liver, then the levels can be very high. But usually it is around 100 to 200. That's the amount of liver enzyme elevation that you get. What about platelets? Platelets have to be low, and that criteria is less than 1 lakh. What about LDH? It is obviously going to increase when there is hemolysis. So it is, the definition is more than 600. So what about intrahepatic cholestasis of pregnancy? That's something which happens in the second and the third trimester. And in the AST/LT are usually in this case less than 500. They never go beyond 500. And you have to remember this is a cholestasis which is happening. So the predominant issue here is the bile acid or the jaundice which is happening. So the bile acid concentrations will be very elevated in this intrahepatic cholestasis of pregnancy. What about acute fatty liver of pregnancy? So this is one very, very dangerous condition that can happen to patients in the third trimester. And there will be some modest elevations of the AST/LT, which is less than 500. So the major issue with acute fatty liver of pregnancy is basically almost the patient going into liver failure in a pregnant patient. So this is what is acute fatty liver of pregnancy. And if you see here, patients will have high WBC counts, deranged INR values. If you see here, in none of these conditions have got any deranged INR values, but in an AFLP case or an acute fatty liver of pregnancy, you will have elevated INR. You might have decreased platelets as well, decreased glucose because there's liver failure happening. You will have elevated uric acid and ammonia levels as well. So this is how you can broadly classify your liver disease of pregnancy, and based on your clinical features and your AST/ALT levels, bilirubin levels, and the other levels that I told in AFLP, you can have a differential diagnosis of the liver disorders in pregnancy. Thank you for your patient list.
Thank you, Dr. Rohit. Dr. Satyajit is going to complete his presentation. You can share your slides now, Dr. Satyajit.
Yes, sir. Is it visible?
Yes, visible.
So we are discussing about tumor lysis syndrome. We discussed about pathophysiology, then what are the hematological malignancies associated with TLS, then what is the Chiaro-Bishop classification of TLS. Now risk factors, intrinsic tumor-related factors, and patient-related factors. In patient-related factors, if prior to starting the treatment of or starting chemotherapy, patient is already having hyperuricemia with uric acid level more than 7.5, or pre-treatment hyperphosphatemia, pre-existing nephropathy or exposure history to nephrotoxins, or there is inadequate hydration during treatment, or intensity of chemotherapy, radiation therapy, targeted therapy, some degree of renal insufficiency. So in these cases, the patients are prone to develop TLS. Now coming to the signs and symptoms, though not specific to TLS, patients may present with symptoms related to the electrolyte imbalance that occurs due to TLS, like generalized weakness, lethargy, nausea, vomiting, diarrhea, dyspnea, pulmonary edema, altered sensorium, stupor, seizure, muscle weakness, tetany, palpitation, arrhythmia, and ECG changes like arrhythmias and sudden cardiac arrest. There are certain signs and symptoms due to cellular metabolite released into the circulation. Like as we discussed, hyperphosphatemia, hyperuricemia, they can lead to anorexia, lethargy, and also hypocalcemia lead to arrhythmia, tetany, and seizures. And features of hyperkalemia include muscle fatigue, arrhythmia, and sudden cardiac arrest. Also, in rare cases, TLS is also known for its atypical presentation like intestinal perforation. Now, how we're going to prevent TLS? Before managing, we should focus on how to prevent TLS to develop. First thing is, and most important thing is maintenance of hydration. The mainstay of treatment in prevention of TLS is adequate hydration, that is about more than 3 liters per meter square per day of IV fluid. Patients should receive at least IV fluid of at least 3 to 4 ml per kg per hour with a targeted urine output of more than 1 ml per kg per hour. Urine alkalization, although it's not very convincing, because the theory is uric acid is highly soluble in alkaline pH, and this raises the theoretical concerns of rapid elimination of uric acid. But In order to achieve this alkalization, we have to infuse sodium bicarbonate, which in turn precipitates purine metabolites like xanthine and hypoxanthine before formation of uric acid. So this negates the potential advantage of uric acid elimination by urine alkalization. So currently, we are not recommending to transfuse or infuse sodium bicarbonate in order to alkalize the urine. In prophylaxis with uricosuric drugs, mainly we'll discuss about allopurinol and rasburicase. Allopurinol is a xanthine oxidase inhibitor. It works by reducing the production of uric acid in the body, specifically conversion of hypoxanthine to xanthine and xanthine to uric acid. As we had seen previously in the first time, how it inhibits xanthine oxidase. By doing so, it helps to prevent the formation of uric acid crystals, particularly in the distal renal tubular system. This is important because the acidic environment in the distal tubules promotes the precipitation of uric acid as insoluble urate salt. So allopurinol does not increase the breakdown of any existing uric acid that has already been formed. Therefore, its therapeutic effects are not immediate, and it may take up to 72 hours to become noticeable. This shortcoming is taken care by rasburicase, which is a synthetic version of enzyme urate oxidase. So its primary function is to convert urate into allantoin, which is a highly soluble form, and its solubility is around 10 times higher than uric acid. So unlike allopurinol, rasburicase has an immediate effect and can act on already formed urate. So it rapidly reduces plasma uric acid level within 4 hours of IV administration. So allowing for early initiation of chemotherapy compared to allopurinol. That is its greatest advantage. So in a retrospective analysis, it has been found that rasburicase has high chances of prevention of TLS, and it significantly shortens the ICU stay and economic burden. Febuxostat is a xanthine oxidase inhibitor. It has been tried as an alternative to allopurinol. This is the difference between allopurinol and rasburicase. Dose 3000 milligram per meter square per day is required for allopurinol. Rasburicase, as it is administered IV, it's only 0.2 milligram per kg. Allopurinol has got slow onset of action, and rasburicase has rapid onset of action. And allopurinol effectivity is very less compared to rasburicase. But rasburicase has a problem of hemolysis in G6PD deficiency patients. And immune reaction probability is higher in rasburicase treatment. Now, before initiating the treatment or management, we need to know what are the low risk category, intermediate risk, and high risk patients who require or who are susceptible to develop TLS. Among malignant disease, solid tumors, they belong to low risk group, and hematological malignancy, myeloma, it also belongs to low risk group. In chronic leukemia, CML patient in chronic phase and CLL patient therapy using alkylating agent, they are usually low risk group. And then CLL patient who receive targeted or biological therapies, they are intermediate risk group to develop TLS. And in acute leukemia patients, AML, usually here we need to know about TLC count and LDS value. If TLC count is less than 25,000 and LDS value is less than 2 times elevated than the upper limit of normal, then they belong to low risk group. But if LDS is had or elevated more than twice the upper limit of normal, with a TLC count whether less than 25,000 or more than 25,000, they belong to intermediate risk category. And if TLC count is more than 1 lakh, then it's a high risk disease group. Then among ALL patient, again same, TLC less than 1 lakh with LDS value less than 2 times elevated, intermediate risk group, and more than 2 times elevated belong to high risk group. And if TLC is more than 1 lakh, then high risk category. And Burkitt lymphoma patients, they are always high risk group, very prone to develop hemolysis syndrome. So how we are going to manage as for the risk category? In low risk group, the patient can be managed only with monitoring, careful monitoring, and measurement of fluid status, daily input-output monitoring, laboratory results, and IV fluid administration. And allopurinol we may or may not give prophylactically. In intermediate risk group, patients should be offered up to 7 days of allopurinol prophylaxis along with increased hydration post initiation of treatment or until risk of TLS has resolved. But in high risk group, we need to give raspuric acid prophylaxis better to avoid TLS. Now coming to management, again ABC is to be evaluated airway, breathing, circulation and managed depending on the severity of symptoms and presentation. Patient may need mechanical ventilation if severe hemodynamic compromise is there or severe metabolic acidosis is present. Hydration target, as we discussed, IV fluid around 3 liter per meter square per day and target urine output more than 100 ml per hour at least. And if it is less, we can add diuretics if urine output is less. Then serial lab monitoring, 6 hourly or 12 hourly, depending on the risk and severity of serum uric acid, calcium, phosphorus, and lactic acid. And chemotherapy should be deferred by around 48 hours if patient is not adequately hydrated or deranged laboratory parameters are present. Then low intensity treatment like single drug regimen or mono regimen can be restarted based on the reversal of symptoms or normalization of lab value. This is the flowchart of management of TLS. Um, First thing is risk stratification, then baseline vitals monitoring, baseline laboratory parameters monitoring, any life-threatening conditions like severe metabolic acidosis present. If it is present, then we have to take care of the airway and initial mechanical ventilation and vasopressor support if required. If there is no life-threatening condition, then management is based on risk category. That is adequate hydration, allopurinol, raspuricase. They should be started as prophylactically. Then if we achieve hemodynamic stability or clinical stability, then we should measure the serum uric acid level and other electrolytes. If uric acid level is less than 8 milligram per deciliter, then allopurinol 300 to 600 milligram per day OD or once in 2 days prior to chemotherapy, and IV hydration should be maintained. If uric acid is more than 8, then we need to give raspuricase 0.15 milligram to 0.2 milligram per kg IV daily for 3 days, and it may be given up to 7 days. Similarly, electrolyte dyselectrolytemia like hyperkalemia, hyperphosphatemia, and hyperuricemia should be managed. How? These are the management of complications. Hyperkalemia usually it leads to muscle cramp, arrhythmia. So it can be treated with calcium gluconate, IV dextrose with insulin, sodium bicarbonate, loop diuretics, and if required, hemodialysis may be considered. Similarly, hyperphosphatemia, it is managed with aggressive hydration, 25% dextrose with insulin, oral phosphate binders, non-calcium based, of course, and hypocalcemia is managed. First, hyperphosphatemia needs to be managed because that is the reason for which hypocalcemia is developing. And for that, in order to correct, we can give calcium supplement also to increase the calcium level. And hyperuricemia, it leads to usually acute renal failure, so adequate hydration, allopurinol, and urate oxidase needs to be administered. And in emergency cases, we may require hemodialysis in order to manage hyperuricemia. So this is the management of TLS. Thank you. Hello. Next slide is Dr. Sanjeev will present.
Next, I think me. Is it visible now?
Yes, it's coming.
So, good evening, everyone. I am discussing this topic trauma in ICU patient. So my objectives of a presentation will discuss under the heading of scoring systems and initial assessment of the trauma patient and initial resuscitation and management, and subsequently pharmacotherapy in trauma patients. So there are many scoring system till with the trauma patients. Some are the anatomic scoring system, or some are based on the physiologic basis, and some scoring system are based on both of these. So anatomic scoring system, these are abbreviated injury scale or injury severity scale, new injury severity score, and so on. And physiologic scoring system, these are the revised trauma scoring system, Apache score, SOFA score, SAS criteria, and emergency trauma score. And the combined scoring system, these are the TRIS or trauma score, injury severity score, or HASCOT score, and IC, ISS scoring system. So abbreviated injury scale, these are some of the common scoring systems that are used in ICU. So these are based on the anatomically classified based on the anatomy, and consensus derived global severity scoring system. So classifies each injury by the body region according to its relative importance on a 6-point ordinal scale. So each of the body part is like head and neck, face, chest, abdomen, and extremity, and external body part, or all are given a 1 to 6 scoring system. 1 being the minor, 1 being the least injury, and 6 is the most critical injury. So each body part is given a scoring system from 1 to 6, and all the scoring systems are summed to get the final scoring system. Another scoring system is the revised trauma scoring system that take account into respiratory rate and the systolic blood pressure and Glasgow Coma scale. And the least score is the 0, and the most the highest score is the 12. So which scoring system is better? This is a study that have shown that we determined that the anatomical trauma scoring system predicted the hospitalization and ICU necessity better, whereas the TRIS and anatomical physiological scoring trauma scores are defined in the ICU hospitalization and mechanical ventilation time better. So another study, this has compared the physiologically based trauma scoring system are much better predictor than the anatomically based scoring systems. So coming to the initial assessment of the trauma patients. So coming to the primary assessment of the patient. So while assessment, we should do assessment altogether, like airway, breathing, circulation, disability, and exposure, and simultaneously we should do also resuscitation. For assessment, we should not delay the resuscitation in trauma patients, because time is very important in trauma patients. So we assess the airway maintenance with a restriction of the cervical spine. So not only we check the airway, here we check the cervical spine, whether there is injury to the cervical spine or not. In breathing, we see the breathing and whether patient is breathing, taking breathing spontaneously or not, and the patient is ventilating properly or not. And circulation with hemorrhage control, and disability assessment whether there is individual disability or not, and exposure and environment control. So these are the ABCD basically we will start with. So coming to airway management, so we should do a rapid assessment to see whether there is any foreign body inside the airway to cause the obstruction, whether patient is secretion in the airway, or any hemorrhage inside the airway, or any broken tooth, all this, or any foreign body we should see inside the airway. And if patient is having a GCS of less than 8, or in case of any doubt about the patient's ability to maintain airway, we should go for a definite airway. And we should take care to prevent the excessive movement of the cervical spine, because any movement that may subsequently lead to injury, motor paralysis. We should, if there is a difficulty in accomplishing a definite airway, we can go for a surgical airway. So breathing, we should expose the neck and the chest, and see the properly inspect and palpate and auscultate the chest to see whether the patient is properly taking breath or not. And if there is, we find any signs of tension pneumothorax or submassive hemothorax or open pneumothorax or tracheobronchial injury, we should secure the airway, and we should do insurance drainage of the tension pneumothorax. and we should also give oxygen and monitor the pulse oximeter to maintain the oxygen saturation more than 90 to 94%. Coming to the circulation, here we see the heart rate and blood pressure of the patient. If patient is having hypertension or pulmonary injury due to blood loss, always if patient is having hypertension, you suspect that this is due to blood loss until this is proven. So clinically, we should observe with when there is hypertension, we can clinically observe that this patient have a cold climate screen and there is a low level of consciousness and a patient may have tachycardia. So we should properly identify the source of bleeding, whether this is a external bleeding or internal bleeding. If there is external bleeding, we can give you a manual compression to check the bleed, and if this fails, we can give a tourniquet when there is a bleeding from the limb. If this is a internal bleeding, such as if this is bleeding inside the chest or inside the abdomen, so accordingly we can do a proper investigation. Inside the chest we can do a fast scan, and also inside the abdomen we can do a fast scan to see whether there is intra-abdominal or intrathoracic fluid collection. So accordingly we can take the proper step. So we can do a chest X-ray and pelvic X-ray and fast scan and a diagnostic peritoneal leverage. So if required, you can give a chest decompression, and if there is a patient hemodynamic instability and massive hemothorax, so you can go for the chest decompression and pelvic stabilization if there is having a patient pelvic injury, and sprint as per requirement. And also surgical and radiological intervention if a patient having active internal bleeding. So disability, we should check for any level of check for the level of consciousness and size of the pupil and reaction, and presence of any lateralizing sign and spinal cord injury. So coming to the exposure, completely unrest the patient to do a complete head to toe examination and do the proper assessment, and simultaneously after assessment we should cover the patient with warm blanket and do an external warming, because these patients are prone for hypothermia along with the massive hemorrhage. So what are the adjustment to the primary survey? These are some of the adjustment to the primary survey. We should go after the primary survey. We should do the ECG and pulse oximeter, and we should go to check the capnography and arterial blood gas analysis, and we should put an urinary catheter and a police catheter, urinary catheter and a nasogastric tube, and do imaging like chest X-ray, fast scan, and if extra fast scan and diagnostic peritoneal lavage. So after the primary survey, we should continuously examine the patients. So we do the secondary survey. In secondary survey, we take a history of the proper history of the patient and do a physical examination to get more information. In history, we see the ample history. Ample means the allergy, whether the patient is having any allergy, medication, recently patient was taking any medication, past illness or pregnancy, and last patient had taken the milk. Just we check that patient did not aspirate, and if you check the emitter or inherent related to the injury, the circumstance under which the patient undergone the or sustained the injury. So while we should do a brief clinical history, we should not delay for the treatment part further taking the history, and we should ask the patient relatives about the mechanism of injury, whether this is a blunt type of trauma, penetrating type of injury, or any, or whether the patient has sustained the bone injury. But after that, we should do a physical examination from head to toe: head, eye, cervical, spine, and neck, abdomen, pelvis, and chest, perineal, rectum, and vaginal examination. So we should not miss this one, and musculoskeletal examination, and also neurological system examination. So what are the after the secondary survey, what are the adjunct to the secondary survey? We should do additional X-ray examination of the spines and extremities if required, and a CT scan of the head, chest, abdomen, and spine, and contrast urograph and angiography patient required, and transesophageal ultrasound or bronchoscopy or esophagoscopy. So if a patient have a hemorrhagic shock, this hemorrhagic shock can be categorized to 1, 2. There are 4 categories of shock according to the American College of Surgeons. So this class 1 is the minor or least type of least severity type of shock, and 4 is the most severe type of shock. In type 1, the blood loss will be up to 750 ml, and patient will have a compensation to that, and a patient maintains vital. But in type 4, the blood loss will be more than 2000, and patient don't have reserve to tolerate this amount of blood loss. So percentage of blood loss will be up to 15%. In type 2, the percent of blood loss will be 15 to 30%. In class 3, the percent of blood loss will be 30 to 40%, but in class 4, the percent of blood loss will be 40%. So pulse rate, blood pressure, patient initially maintain the pulse rate and blood pressure, but in type 4, patient usually have a tachycardia and a decreased blood pressure. Also in type 3, patient will have a decrease in blood pressure. Pulse pressure, initially patient maintains the pulse pressure, but subsequently as the severity goes on, the pulse pressure again decreases. So urine output, again patient met initially in type 1, patient went to the urine output, but subsequently drops from 2 to 4th category, where the patient will have anuria. And subsequently patient have altered mental status in type 3 and 4. So the risk is equal to the trauma resuscitation. This is just a shared mental model to so first assess and manage the immediate life-threatening injury if there is. So find the massive external hemorrhage and take action is the control or compress the external hemorrhage. If there is airway compromise, give high flow oxygen and suction, just thrust and oral or nasal put a nasal or airway. If the immediate definitive is required, then immediate definitive air is required if there is a dangerous sign of hypoxia or a dynamic airway obstruction or dynamic airway injury. So if this hypoxia or airway injury there, so proceed with the airway intubation or surgical airway. If this hypoxia or airway injury is not there, so do again the focused evaluation of airway and breathing circulation and do a focus. So and simultaneously see whether patient is having shock or occult shock. So this shock is identified if isolated or persistent systolic blood pressure is less than 110 millimeter of mercury, or shock index is more than 1, or ultrasound you see the IVC is flat, or there is along with hemorrhage sign and symptom, hemorrhage or evidence of hemorrhage in any body part, or lactate is more than 4, or loss of central pulse, or polyperfused extremity. So if patient is having shock, do a targeted intervention based on the suspected shock etiology. So decision to intubate, if the patient is taken to intubate, so consider in this patient we should do with induction agent 22 to 50% of the usual dose of the induction agent. While paralytic dose, we should give a full dose of paralytic dose, and subsequently we monitor in an ICU setup. But if a patient do not require intubation or transfer to ICU or operating room, and for the securing of the bleeding vessels. Currently, we should manage with the blood product and tranexamic acid and peligrander if is required, chest decompression if required, and surgical management of the tamponade whatever we see abnormality associated with the patient. So along with that trauma patient, along with the major bleeding, what could be the more concern to us? This is the known as the lethal triad. In a patient who is having massive hemorrhage, usually this patient usually go to the hypothermia, and hypothermia subsequently lead to acidosis, and acidosis again leads to a coagulopathy, and coagulopathy again causes more bleeding, and subsequently more bleeding leads to hypothermia. So this is a vicious cycle goes on. So the triad leads to a more lethal fate subsequently. So we should check, our target should be check this vicious cycle. So the lethal triad, if you see, if both all the three are present, the hypothermia, the acidosis, and the hypertension, if all these are present along with the injury severity score of more than 25, the mortality is almost 98%. So managing coming to management of the trauma patient, trauma should be managed with a there are three things you should focus on: the damage control surgery initially, then early hemostatic resuscitation, and along with the permissive hypotension. These three altogether known as the damage control resuscitation. So, what are the indication of the damage control resuscitation? If the patient having anatomic parameters like injury severity score is more than 36, or penetrating injury, or penetrating abdominal injury, chest injury, or open pelvic fracture, long bone fracture with head injury, or long bone fracture with lung contusion, or truncal hemorrhage or amputation. And physiological parameters like weak or absent radial pulses, core body temperature less than 35, or systolic blood pressure less than 100 milliliter mercury, tachycardia, heart rate less than more than 100, and a PF ratio less than 250, or urine output is less than 50. And lab parameter lactate is at 2.5, and platelet count is less than 90,000. Fibrinogen is this is less than 1 gram per deciliter. PT is more than 16, iron more than 1.5, hemoglobin also less than 11, and the patient having acidosis. In those cases, we should go for a damage control resuscitation. So, in damage control resuscitation, it should be planned temporary if required. Initial for the damage control resuscitation, we do surgery. We should go for a planned temporary sacrifice of the normal anatomy. If suppose the patient having traumatic injury to the leg and the patient is properly bleeding, so in these cases, we should if required to control to save the life and control the hemorrhage, we may need the amputation to the limb. So this damage control surgery consists of initial abbreviated laparotomy or ICU ICU resuscitation and subsequent reoperation of the definitive resuscitation. So initially we don't go for a definitive surgery. Initially we check the breather and we send the patient back to the ICU and do the appropriate resuscitation with crystalloid or colored blood product. And subsequently after patient stabilization and improvement, we do a definitive surgery for the patient. So, so for initial resuscitation, it is not possible to restore the normal physiology until we check the hemorrhage or hemorrhage. We have not checked the hemorrhage. So normal physiology we cannot restore. So in those cases, if I found any breeder, we should check that, and if required, we put a pelvic binder or compression dressing. If required, we see any external bleeding, and a tourniquet if required any like in any bleeding from the limbs. And subsequently, we keep it unexamined. This had some mortality benefit, and we in a polytrauma patient bleeding, we usually give it unexamined. So, if there is a surgical hemorrhage, surgical hemorrhage controls is a gold standard if we find any active hemorrhage site. And alternatively, we can give an internal radiologist call, and we check the bleeding if there is bleeding inside. So in the damage control resuscitation, our aim is to achieve the subnormal blood pressure to minimize the hemorrhage. So usually our target is not to maintain the normal blood pressure or normal maps. In these cases, we usually keep our target blood pressure a bit low. So target to check the or minimize the hemorrhage in the initial part of the resuscitation. So target our systolic blood pressure should be about 80 millimeter mercury rather than 100 or 100 millimeter mercury, and MAP should be 50 millimeter mercury rather than 65 to 70 or more than 70 millimeter of mercury. But this damage, this low, permissive hypotension is not applicable in patient having traumatic brain injury. So for monitoring in this patient, we should monitor the lactate and venous oxygen saturation. And current advice is to avoid this approach, as I told, in a traumatic brain injury patients. And aggressive resuscitation with crystalloid that decrease the intestinal perfusion or increase the intraabdominal hypertension, multi-organ failure, and death also. So we should initially we should have a we should not do an aggressive resuscitation, rather a restrictive resuscitation. So whether we should give a crystalloid, there are many studies. They have study has shown that aggressive resuscitation has many disadvantages like dislodging of the soft clot and dilution of coagulopathy and accelerated hypercellular injury. Also increase in the rate and volume or duration of the hemorrhage. Increase the duration of the hemorrhage also. So while keeping which type of fluid we should use for the resuscitation, whether ideally we should give a crystalloid, colloid, or a blood product. Ideally we should give the blood product when if it is available immediately, but if blood is not available immediately, we can go for the crystalloid that we can give, but we do not give too much of crystalloid, but or we not aggressive resuscitation, rather than we give a conservative approach. As I told, that may otherwise if you give aggressive reaction, that may lead to more hemorrhage. So very early use of blood and blood product are the primary resuscitation fluid. Hemostatic resuscitation aims to deliver a mixture of RBC, fresh plasma, and the platelet in 1:1 ratio. Casualty who require continuous reduction, massive transfer protocol may be required, and studies have shown that massive transfer protocol activated, death significantly from the trauma has decreased. So another thing is the warming of the patient, because patient are hypothermia. To break the dangerous triad, we rewarm the patient simultaneously. So there are three types of rewarming: passive, external rewarming. We can, for that we can give the warm blanket or increase the room temperature. For active rewarming, we give a first air warmer that usually we have available in our ICU. And active internal core warming, for that we can give a warm fluid or heated oxygen or warm bladder or peritoneal irrigation. And usually we give increase the body temperature by 4 to 5 degrees per hour. So other which our target is the restoration of organ perfusion through the volume replacement, best achieved through the best achieved through aggressive blood and blood product administration alongside the appropriate use of vasopressor. No studies have shown any advantage to the pharmacologic management of acidosis in trauma patients. So there is no benefit of bicarbonate or trees for the management of acidosis. So we have shown that blood ideally should be given. After that, if it is not available, we should go for crystalloid. But what about the other color like hexacyl starch or albumin? So I'll just going through this this may not look at much in depth, but their study, SAFE study, this has used the albumin. They did not find any two-stage mortality, but SAFE study in traumatic brain injury, you will see that increases the mortality. This is for important for the TM patient, TM people, for theory and also practical. Because these are the some of the landmark trials. Similarly, chest and crystalloid will compare with the hexacyl starch or colloid. They didn't find any 90 days mortality. But other than that, but hexacyl starch or HES, if you use, that may increase the acute tubular necrosis or increase the AKI. So our goal is adequate tissue perfusion oxygen while correcting the coagulopathy. We may require the massive transfusion protocol at times. So what is the definition of the massive transfusion protocol? If there is a requirement of 10 units of PRBC within 24 hours, which approximately equal to the total blood volume of the patient. Or if the transfusion of more than 4 PRBC within 1 hour with anticipation or anticipation of continued need or a blood product support. Or if there is a replacement of more than 50% of the total blood volume by the blood product within 3 hours. So these are the three definitions of the massive transfusion protocol. In massive transfusion protocol, immediately we will give the O negative ORBC and AB positive AB plasma product should be given until the patient is blood type can be determined. So recommended according to ESICF, European Society of Intensive Care Medicine, target hemoglobin should be 7 to 9 grams per deciliter. Platelet target should be more than 50,000 and maintain the platelet count of 1 lakh in cases of ongoing bleeding or having a traumatic brain injury. So, how much blood or blood product we should be given? This is the trial. I'm going through this one. So, in brief, the proper trial. This trial has shown that 1:1 of the where a platelet exposure plasma and PRBC is better than the 1:2. That is platelet, FFP, and PRBC. So we 1:1 transfusion is better than the 1:2 transfusion. Another from trial similarly suggests 1:1 transfusion. So when how we should assess when the patient is a massive transfusion protocol activation. So this is the one score that is known as ABC scoring system. Its emergency dependent systolic blood pressure is less than 90 millimeter of mercury, or heart rate is less than 120 beats per minute, or penetrating mechanism of injury, or a positive fast. If out of the 4, if 3%, there is 45 chance of massive transfusion. If out all the 4 are present, then there 100% need of the massive transfusion. So this is the massive transfusion. How we should go with the massive transfusion. The senior should recognize the massive transfusion if required, and the senior activate the massive transfusion once. And the trigger should include the following: actual or anticipated 4 units of PRBC in initial phase of resuscitation with hemodynamic instability, or ongoing bleeding with major traumatic or obstetric or GI or surgical bleeding. So first, we order the MTP by calling the blood bank and assign 3 to 4 person ABC. A is the person who admits the blood product. B, who makes the call and check the blood level and send lab and record the transfusions. They are the two, in B group there are 2 people, and C with this 1 person that act as a runner between the blood bank and the patient. So we draw the baseline labs like CBC, PTPT-INR, and fibrinogen and ABG. And patient should be 1 and give 4 units of O negative PRBC and 2 units of AB FFP. And I can reassess whether patient really need this amount of large amount of blood. If yes, then in round 2, give the 4 unit PRBC, 4 unit FFP that received, and 1 platelet back. Then again recheck the lab in every 30 to 60 minutes. And give 1 gram calcium and fibrinogen if fibrinogen is less than 100 mg per deciliter, and give if fibrinogen is less than 100 mg per deciliter, give 1 unit of cryoprecipitate. Again, reassess the patient if again massive transfusion is required. If yes, then go for round 3 in this. Again, recheck whether patient need for a factor 7. And factor 7 should be given after checking whether patient having normal fibrinogen, normal platelet count, and patient having normal acid-base balance, and a patient having controlled surgical bleeding, and patient is a normal therapy. So massive transfusion protocol, another question as far as theory is concerned. So what are the endpoint of the massive transfusion protocol? Endpoint is hemoglobin is less than hemoglobin should be maintained more than 10 gram per deciliter, and prothrombin time less than 18, APTT less than 35, and platelet more than 1.5 lakhs, fibrinogen level more than 100 milligram per deciliter. So trauma-induced coagulopathy, monitoring the coagulopathy. Trauma-induced coagulopathy with platelet dependent platelet is PT is more than 18. Second, INR more than 1.5, or APTT more than 60 seconds, or any of the value more than 1.5 to it's a baseline value or a reference value. So coagulopathy we can monitor with the thrombelastography or rotem. So study have shown that this rotem or take-based transfusion is better than the our massive transfusion protocol. So these are some of the study that supported the take-based transfusion. I'm not going in depth into the take, and this is yet another very important question for practical and theory purpose also. So we can remember this table. So reaction time, if it is reaction time determines the formation of clot. So if R time is more than 11 minutes, so we should give you the FFP or FTP. We should give the transfusion plasma. If maximum amplitude is less than 54, so there is clot. This is known as the clot's maximum amplitude or clot strength. If it's less than 54, then we should give the platelet or cryoprecipitate for this patient or fibrinogen. And if lysis time after maximum amplitude, lysis time 30 minutes after the maximum amplitude is more than 3%, we should give the tranexamic acid because this indicate one fibrinolysis state. So what are the pharmacotherapy we can give in trauma patient? Tranexamic acid is one of the important drug that indicates the mortality that is proven in the crash to trial. We should go through this landmark trial. And another matter trial, military application of the tranexamic in trauma emergency resolution is also support the tranexamic acid. We usually keep 1 gram tranexamic acid within 1 hour. Ideally within 1 hour as per the this crash to trial, and that should be given 1 gram over the 10 minutes. Subsequently, we should give 1 gram over 8 hours thrice daily. But tranexamic acid should not be given if it is given after 3 hours, as to increase the risk of death due to bleeding. So this is should not be continued for a day 2 or day 3. We should that is limited to only day 1. So fibrinogen concept in patient with a blood loss, fibrinogen has been reported to decrease more rapidly than the other coagulation factor, and this is the study in JAMA trauma acute care surgery. This shows that 30-day mortality was comparable, and 6-hour mortality was significantly lower in patients receiving the fibrinogen. Cryoprecipitate is we should give it if patients have low fibrinogen concentration, and but there is no report suggesting positive effect of cryoprecipitate administration on survival of extended patient. What disadvantages are the availability and allogenicity, and the need of blood type matching, and the time for consuming thawing. Calcium, if we are giving a massive transfusion, we should give calcium because there is chance of decreased ionized calcium because of citrate in the blood, in transfused blood. And recombinant factor 7, we should after normalizing all other clotting factor, we can give the activated factor 7. And this is off-label use, but there is a non-definitive study that compared the mortality with a factor 7. But there is associated increase thrombotic risk if we use this. So vasopressor, there is urgent vasopressin release occur early in major blood loss and assist in centralizing the remaining circulating volume to the brain, heart, and lung. So vasopressin depletion occur early in polytrauma patients. So some of the studies suggest that vasopressin may improve the outcome if combined with the rapid hemorrhage control and improve the blood pressure with while not worsening the blood loss. But there is insufficient evidence to define place of vasopressors in early trauma resuscitation. So coming to the steroid, as far as the drug therapy in spinal cord injury patients, there is the ATLS guideline. Recent ATLS guideline does not mention about a particular whether to give methylprednisolone in spinal cord injury patients, but current guidelines they also against the giving the high dose of steroid or methylprednisolone in spinal cord injury patients. So these are trauma and trauma-related resuscitation. Thank you.
मैं स्टॉप शेयर करती हूँ. Hello everybody, am I audible? Am I audible? Should I start?
Yes.
Yes.
Audible.
Okay. Okay, very good evening, everybody. This is my second presentation today. It is like approach to critically ill multi-trauma patient. Before I go to slides, I'll tell that most of the theory topics has been covered related to trauma. They're in the previous session by Dr. Sanjeev. Obviously, it was for transfusion and blood product, but he has covered most of the aspects. Okay, and this is just an overview. I will not go into detail. This is just a overview and the overview of the things which we will follow when your trauma case come to you. But your theory parts, most of these parts have been covered, okay, including the resuscitation, damage control aspects, surgeries, blood products, even the airway and ventilation part. Okay, so some of the slides may coincide with both of us, same from the ATLS guideline only. Okay. Okay, coming to just introduction part. According to WHO and CDC, more than 9 people die every minute from injuries or violence. Okay, trauma is that much, incidence is very high. RTA is the leading cause of death due to injury worldwide. And more than 90% of motor vehicle crashes occurring in developing world. Okay, we are sitting in the developing country like India, where the RTAs are predominant cause of death. Okay. There is trimodal distribution of trauma-related death. Everyone is aware of that is immediate at spot, then within hours of injury, then the delayed complications. Whatever the patient survives, but the delayed complication related to that trauma. Okay, the golden hour concept of ATLS. ATLS is acute trauma resuscitation. The golden hour is the first hour after injury. Okay, this is the first hour is very much important to concentrate and give effective therapies during the first hour, which is very much important, so that the outcome of this patient will improve if first hour resuscitation is very good. The concepts of ATLS started in 1978, and the concept is like to treat the greatest threat to life fast. Okay, never allow the lack of definitive diagnosis to impede the application of an indicated treatment. Okay, and detailed history is not essential to begin the evaluation of patient with acute injuries. Should not delay resuscitation, all that, taking history. And definitive diagnosis, never allow the lack of definitive diagnosis to impede the application of indicated treatment. First is treatment. The trauma is emergency. The result was the development of ABCD approach. This leads to evaluation and treating the injured patient. Okay. The concept is first preparation, trials, primary survey, adjunct to primary survey, need for transfer if it is there is obvious need of transfer, and secondary survey and adjunct to secondary survey. Then pre-hospital preparation, because some of the slides are pre-hospital part. Okay, I have kept it, but I'll go through rapidly. Main importance is the in-hospital part. Okay, information provided by emergency response team, basically the mechanism of injury, the clinical, the patient's vitals, and type of injury, apparent injuries. Okay, early notification to the transfer hospital is most important, so that they are ready with that. The field trials, okay, it is at the site of injury. We see these are the various vital parameters to see if there is abnormal anything, like here the parameters are written. Then transport to appropriate trauma center is needed, and the type of injuries. Okay, if there is penetrating injury, chest wall instability or deformity is there, long bone injuries, cross, deglove, mandible injuries, and amputation is there, pelvic fracture, open fractures. These are the candidates. This would be transported to appropriate trauma center from the field very rapidly. Okay, and patients with history of fall and high risk of motor vehicle crash. Okay, there are various subheadings are there. The severity of the injury. This would be rushed to the appropriate trauma center. Trials is the sorting of patient based on the resource required for the treatment and the resource that are actually available. Okay, what are the resources needed and what are the resources we have. The severity of injury and ability to survive will allow these resources to there. Then for that, various pre-hospital trauma scoring is needed. Trial scoring is there. In multiple casualties, number of patients and the severity of the injuries do not exceed the capability of facility to render care. But in mass casualty, number of patients and the severity of the injuries does exceed the capability of the facility. The patient with greatest chance of survival and less resource requirement is first. Okay, that is the concept of trials. Then I'll come with a case. Okay, you people will be telling 20-year male patient on motorbike. He had a road traffic accident with head-on collision with the car and presented to our emergency department with GCS of E2, V2, and M4. Okay, like his GCS is 8, heart rate is 124/minute, high but sinus tachycardia, blood pressure is obviously low. He is abnormally breathing with respiratory rate of 50/minute. Then how will you approach this case? Okay, he has suffered a RTA with head-on collision with hypotension, tachycardia, altered sensorium, obviously could be associated traumatic brain injury, other abdominal injuries, long bone injuries, even to chest injuries, abnormal breathing with there can be rib fracture, flail chest, pneumothorax, everything is possible. Okay. Then in hospital preparation, we have to activate the trauma resuscitation team in the available area, prepare for everything like intubation, even chest tube placement, and all the laboratory facilities with our ultrasound, CT scan facilities should be ready with. Then primary survey, obviously ABCD approach, airway maintenance, breathing, circulation, disability, and exposure. Then comes to airway maintenance. The first important is we have to identify the compromised airway, then management of the airway, and the most important thing in the trauma case is to avoid excessive cervical spine movement. Then how to identify the compromised airway? The patient is unable to communicate, obviously GCS less than 8, he is agitated, upturned, abnormal posturing, noisy breathing like stridor, snoring, gurgling, hoarseness is there. These are the signs of compromised airway that he needs a definitive airway for the maintain the airway. Then other like use of accessory muscles, he is like abnormally breathing, inspection for any foreign bodies there, identifying facial, mandibular, tracheolaryngeal fractures and other injuries, there is a threatened airway. Then for airway management, suctioning, chin lift and jaw thrust. Basically triple maneuver is head tilt, chin lift and jaw thrust. Here in the trauma case, we have to avoid the head tilt, the chin lift and jaw thrust is most important, okay, to prevent the cervical spine injury. Then oropharyngeal, nasopharyngeal airway, supraglottic airway, adjunctive devices, and most importantly, all the equipments for the definite airway access, endotracheal tube, various sizes, all adjunctive devices, and even preparation for the surgical tracheostomy if it is needed. Then indications for definitive airway, where we have to think for obviously definitive airway is needed when that is unable to maintain a patent airway or other means with impending the potential airway compromise like inhalation injuries, facial fracture, retropharyngeal hematoma, and patient unable to maintain adequate oxygen by oxygen supplementation, face mark, or there is apnea, then we have to need of definitive airway. They are obtunded, combative, and GCS is less than 8 with sustained seizure activity. We have to need to protect the lower airway from the aspiration, blood, or vomitus. These are the candidates for definitive airway access. Obviously, before intubation, we'll think for the Lemon rule to look evaluate mallampati gradient, obstruction, and neck mobility for the difficult intubation. Okay, I'm going rapidly because this is just an overview. Then for airway maintenance, what is important in the pre-oxygenate, if you are able to oxygenate, then assess for airway anatomy, and if it is EG, then proceed for intubation. If unable to oxygenate, then definitive airway or surgical airway should be assessed. If airway anatomy is difficult, then do not hesitate to call for assistance. Okay. With difficult airway, there is always considered the airway adjuncts like bougie, light bands, laryngeal mask airway, all that, and definitive airway. If it is not possible, then even tracheostomy or surgical airways. Drug assisted intubation, when there is difficult without assistance of drug, then drug assisted intubation is now promoted, that is pre-oxygenate, required pressure, and use of short acting muscle relaxation especially, and induction agents like etomidate, which are stable, cardiostable, and they are less hemodynamic instability with use of etomidate, sedative agents, less use and administration of scoline, suction and scoline of 1 to 2 milligram per kg. That is for drug assisted intubation. Then what is important is restriction of cervical spine motion. But there we have to, in blunt trauma patient, high chance for cervical spine injury. Okay, though it is less there in the penetrating injuries. Blunt trauma, they are think for cervical spine injury always. Routine immobilization not needed for obviously penetrating injuries. We need a rigid cervical collar, barrier to lateral head movement, and a long backboard. Here in the picture, it is shown. During placement of long backboard, you look for any spinal step up or tenderness. If it is tenderness there, obviously there is cervical spine injuries there. Then during airway management, cervical collar is open, and what is important in the meals is manual inline stabilization. This is very much important component for airway maintenance in trauma cases where there is suspected cervical spine injury. Meals is first is we have to crouch the bedside. Besides the two types, it can be given. I'll show the picture. Crouching besides the intubator with hands placed on the patient master process of cradling the or standing beside the patient in front of the intubator. Okay. Here, see the picture. Here in the meals, she is meals provider. The intubator is not seen. Let here in the picture, intubator is the head end, and she is providing the meals, like crouching the head, okay, over the both side of the head, like over the master person, and she is stabilizing over the hands are there in the chest of the patient. Okay, so the head tilt is being avoided here, and cervical spine is being stabilized. Or here at the head end, over the mastered process, and giving pressures over the occiput, okay, to limit the movement of the cervical spine. Here same, here the crouching the patients from the end, pressure over the chest areas, and the incubator is incubating in the other end. After ARB maintenance is breathing and ventilation. Supplemental oxygen must be administered to all patients. Then objective signs of inadequate ventilation we have to think. Okay, chest rise is there, movement of air on both sides of the chest, rate of respiration, pulse oximetry, and ETCO2, apnometry. Management, supplemental oxygen with all patients, saturation more than 95 is targeted. Ventilation, needle decompression and chest tube insertion if it is needed. Okay, if there is rib fracture with pneumothorax, then obviously chest tube insertion, needle decompression nowadays not recommended. Now it is for chest tube, early chest tube placement. Circulation is rapid assessment of hemodynamic status after ARV. We have to see the level of consciousness, impaired cerebral perfusion leading to altered level of consciousness, skin perfusion parameter, pulse, the thready pulse, the absence of central pulse or peripheral pulses are very thready. The exclusion of tension, pneumothorax, hemorrhage should be considered the cause of hypertension until proof otherwise. Okay, these are very important causes. Obviously, there is bleeding in the artery that lead to hemorrhagic shock or obstructive shock due to tension pneumothorax. Signs of hemorrhage already described before. The classification according to loss of blood, less than 15% to more than 40% of the whole blood volume loss. Okay, if with the increase in severity, obviously if you have grade 3 onwards, there will be decrease in blood pressure. Okay, and there will be more acidosis and base deficit will increase. The class 3 and 4, there is obviously the need for transfusion. Then management of bleeding, obviously already covered also. Identified control during primary survey, external, internal, they are identified in the secondary survey. And surgical and interventional radiologist management, pelvic vitals, long bone stabilization to prevent the internal bleeding. Fluid resuscitation, okay, large bore IV cannula, blood and blood product. The blood is first, okay. Do not give more crystal alerts for that. Hemostatic resuscitation and damage control resuscitation, okay, is previously asked. Then resuscitation, obviously warm saline, initial fluid bolus, fluid responsiveness, then excessive fluid to always to avoid appropriate fluid therapy, and early blood administration. Okay, blood and blood products with equal ratios of PRV, PP, and platelets. Then what are the responders? Obviously rapid response, those who respond to the transfusion or like resuscitation. They are most important the non-responders, which remain abnormal vital signs, severe blood loss more than 40%, immediate need of blood, emergency blood release is mandatory for that, and even highly likely for operative intervention to control the bleeding. Okay, so these are the non-responders. Okay, when non-responder is coming, we should be on the tip of toes that they can even go directly to OT with need of massive transfusion protocol. Blood and blood product replacement, obviously to restore blood, important for oxygen carrying capacity. Transient non-responder require this much, but rapid responders type and cross-match blood products are needed. Obviously, is previously told, O negative and AB positive FFPs will be kept in hand. Prevention of hypothermia and massive transfusion protocol to be activated. Blood products should be given depending on the coagulation parameter. Okay, so trauma-induced coagulopathy should not be there with mismatched blood product, blood products transfusing in not proper ratios. And pre-hospital tranexamic acid, obviously, as described before, 1 gram loading followed by 1 gram infusion over 8 hours. Okay, especially within 3 hours of injury, should start tranexamic. And calcium administration and reversal of anticoagulation. Other non-hemorrhagic causes of shock like obstructive shock, tension pneumothorax, cardiac tamponade, myocardial infarction, dysrhythmia should be kept in mind. Okay, what is important in circulation is the use of adjuvants like ultrasound. Okay, as I told, not only it is the trauma will lead to hemorrhagic shock, obviously there will be other aspects like rib fracture leading to pneumothorax, that tension pneumothorax and hemorrhagic, the penetrating injuries, even blunt injuries also to chest that lead to our massive pericardial effusion. Okay, and that lead to cardiac tamponade leading to your obstetric shock. Okay, then the Ross protocol is very much important. Started for the trauma cases only. Rapid ultrasound for hemodynamic instability, very much important. I'm not going into detail, but I just telling some views, like we keep in the heart the cardiac probe to see for the tamponade, if it is need to drain that, for IVC collapsibility, for hemorrhagic shock and hypovolemic shock to manage, and lungs presence of pneumothorax. Okay, that see for tension pneumothorax, need of ICD there, and here is the presence of Morrison's pouch, like hepatorenal or splenorenal pouch, if there is hemoperitoneum due to blunt trauma of the abdomen or penetrating trauma that lead to that even need for surgeries and massive transfusion for that. Okay, and then other things also associated with, there is traumatic abdominal aortic aneurysm, then also aorta view is important. Okay, it started with high MAP protocol, heart, IVC, Morrison, aorta, and pneumothorax, but later on, like concentrating on the pump, tank, and pipe approach, the rapid ultrasound for hemodynamic instability useful in the trauma cases also, RAS protocol. Then after circulation is the disability, GCS, pupillary size, lateralizing signs, examine the spine and assessment for surgical spinal cord injury, and repeat the examination after some time. Changes in level of consciousness are a result of CNS injury until proven otherwise. Okay, suspected hand injury. Yesterday I dealt with the traumatic brain injury, always presumed to be associated with cervical spine injury, otherwise proven. Otherwise proven like it is not, then always think that there is associated cervical spine injury with the severity of head injury. Then Glasgow Coma Scale and Pupillary Reactivity Score. Okay, these response light key indicators for severity of traumatic brain injury. This provide more information than only GCS for prognostication. If pupillary reactions are there, unreactive to light, if neither of the people is score 0, if both pupils are unreactive, then it is stage 2, like this response is there. Then in GCS 4, then GCS 3 has been solved after using a Glasgow Coma Scale and pupillary activity. We have to combine with here in cases. Then after disability, the exposure and environmental control completely undress the patient, obviously, to see any trauma, which is things which are should not be missed. Okay, the proper even especially is the back parts, like the dorsum aspect of the patient, which are usually missed. Okay, the trauma and those trauma areas which are missed, that should be proper undressing and see for that. Cover with warm blankets, obviously, and warming device after assessment. Temperature control and control of hemorrhage, warm fluids administration, everything is the exposure. Then just a primary survey is the these ECG, pulse oximetry, capnometry, ABG, urinary gastric catheters, and various diagnostic studies. Okay, FAST is focused sonography for trauma, and EFAST, okay, extended FAST approach. FAST is like hepatorenal, splenorenal, and the pelvic areas of ultrasound to see for the presence of blood there. EFAST is the extended protocol where apart from these pelvic and abdominal views, we are extended to the lungs to see for the tension pneumothorax and cardiac tamponade. Okay, as I told before. Even diagnostic peritoneal lavage for blood trauma or traumatic abdominal injuries. Secondary survey does not begin until primary survey is completed, should not interfere the primary survey, head-to-toe examination, okay, detailed history, detailed physical examination, reassessment of vital signs, then investigation is the key factors in the secondary survey. Then here is the detailed history, ample history, like, and every complete medical assessment include history of the mechanism of injury is very much important. Okay, here I'm not going into detail, but some of the mechanism of injuries and suspected things are the blunt injuries. Then what can be the impact, like front impact, then high chances of cervical spine injury, pneumothorax, traumatic aortic dissection, myocardial contusion. Okay, the side impact also cervical spine fracture, lateral flail chest, pneumothorax, aortic disruption, diaphragmatic rupture, or ear impact. There is high chance of cervical spine injury, head injury, and soft tissue injury of the neck. Then fall from height, obviously, high chance of cervical spine injuries, and most important is the abdominal visceral injuries and pelvic injury and acetabular injury. Then penetrating injuries, enterochest wounds, obviously stab wounds, cardiac tamponade, and hemothorax, pneumothorax both. Then abdominal visceral injuries with penetrating injury. Gunshot injuries, high likely of like extremities or brain injury is for the high trajectory, there is high chances of injuries there. Then thermal bonds and electrical bonds, then various inertial bonds are there, which to the suspected pattern of injury with these bonds is here. Then detailed physical examination, head and maxillofacial area, inspect, palpate, reevaluate for people, GCS score, assess areas for hemorrhage, penetrating injuries, and eyes, cranial nerve function, and there's traumatic vein injury like yours also, CSF fluid leakage, everything. Then comes the physical examination, cervical spine and neck, inspect for signs of blunt and penetrating injury, tracheal deviation, use of accessory muscles, palpate for that is, it is like secondary survey, it's complete physical examination, okay. Then SSG chest, very much important, like signs for the flail chest, rib fracture, SSG breathing muscles, and obviously use of ultrasound is clinical. It is a add-on therapy along with the add-on investigating agent along with that the physical examination, okay, which will help in rapid diagnosis. Then abdomen also along with the clinical examination, also the fast scanning and e-fast scanning, okay. And rectal assessment, okay, to any injuries of the perineal injuries, pelvic injury, and vaginal assessment, especially in the female patients. Musculoskeletal, obviously, injuries for the degloving injuries, skeletal injuries, and all that, okay. Then detailed neurological examination, I'm not going into it, even the integrity of the skin. Then adjunct to secondary survey are these investigations or radiographic examinations and ultrasound, diagnostic laparoscopy. And miscellaneous is constant re-evaluation of the trauma patients, okay, what is improving, what is still there to control, and all that. And about analgesia, they are very much in pain, the need of analgesia after stabilization of inter-hospital transfer if there is some definite surgical management needed, which is not needed. Meticulous record keeping, consent before any of the procedure, so, and except the life threatening, and if needed, need of forensic samples for medical legal aspects. Okay, thank you. With this, I conclude my presentation. We'll switch to next session. Any doubts, please put on the chat box.
Hello everyone. Now my turn.
Audible, audible.
Kindly make me host. I am unable to share my screen. Hello.
Dr. Samir, you can present now.
Okay, thank you. So hello everyone. So now we'll be seeing the lab parameters, some practical aspects, okay, in practical exams. So everyone, please. Uh, I don't think anyone is there to moderate today, like Dr. Rohit was there yesterday. So you may switch on your mics to answer. Okay, so I'll start. Are the slides visible?
Yes, sir. Slides are visible.
So 58-year-old man undergoes a thoracotomy, esophagectomy for C esophagus. Then feeding jejunostomy is placed. On day 4, patient is difficult to wean off the ventilator. Okay. So this is the biochemistry. So what are the problems here?
Sir, patient is having hypophosphatemia.
And
hyperchloremia, hypophosphatemia, hypomagnesemia.
yeah, hypomagnesemia. So hypophosphatemia and hypomagnesemia is the abnormality here. So you tell me in which cases can we see these abnormalities?
Refeeding syndrome.
Very good, refeeding syndrome. So this is a case of refeeding syndrome. And what others can cause this thing? Any other, if not exactly this, somewhat similar? Okay, so like diuresis, means it's fusamide diuresis, although the other parameters are somewhat similar, but differentials can be your fusamide and any nasogastric loss. Okay, patient will be having a continuous RT. So the RT secretions, if there is a huge RT uh, output is there, RT drain is high, then that can also cause. Okay, so mostly this is a refeeding syndrome. So other causes of hypokalemic alkalosis, the vomiting, villus adenoma, steroids, pushing, cons, and laxative use. Okay. So now coming to a previously well 24-year-old patient was admitted to ICU 4 hours after an elective arthroscopy with confusion and delirium. Patient has a fever, heart rate of 160, arterial fibrillation, BP of 100/50. So list 3 differential diagnoses. We studied today.
Sepsis.
Okay, sepsis, very good.
Malignant hyperthermia.
Malignant hyperthermia, very good. One more.
Undiagnosed thyroid storm.
Yes.
Thyroid.
Yeah, thyroid storm, very good. Okay, so perfect, all the 3. So now a 36-year-old patient with abdominal pain and distension. He had 2 admissions in the past with similar complaints. So what is the cause of this abdominal symptoms, abdominal pain?
Pancreatitis.
Pancreatitis.
Yeah, very good.
Pancreatitis.
Very good. So your lipase clinches the diagnosis for pancreatitis, and there is a bit of prerenal AKI because your urea is high on the higher side. Okay, so prerenal AKI. And what is the most, do you think, the underlying etiology of this pancreatitis? What can be the cause of pancreatitis in this patient?
Alcoholism.
Yes, alcoholism very common cause, but see this. Okay, I'll give a hint. See the sodium and tell me what can be the cause.
Gallstone pancreatitis. Raised alkaline phosphatase.
Okay, very good.
Yes, yes.
And from sodium, how can we tell? A hint, this is pseudohyponatremia.
Hypertriglyceridemia.
Very good, excellent answer. Whoever answered, that was an excellent answer. Okay, so hypertriglyceridemia is the cause of pancreatitis here. That is the cause of pseudohyponatremia. Alkaline phosphatase is raised. That can also be because of gallstone pancreatitis, and your prerenal AKI is present, metabolic is present. Okay, very good. So how will plasmapheresis help in clearing the triglycerides? Okay. So 34-year-old woman admitted to ICU following the cesarean section for severe preeclampsia and fetal distress. She had been admitted to labor ward 24 hours earlier for the management of preeclampsia. So patient now has bradycardia, slow to wake up, poor cough, muscle weakness, hypotonic and hyporeflexic. Pupils are equal and reactive to light.
Hypermagnesemia due to magnesium therapy for preeclampsia. Eclampsia.
Excellent answer. Okay, so that is because of hypermagnesemia. So patient, there is neuromuscular involvement. Okay, because of magnesium toxicity. So what is the antidote?
Calcium.
Calcium gluconate. Calcium gluconate.
Calcium gluconate. Very good. Okay, and another cause can be incomplete reversal. Okay, that also we had discussed during your today previous class. Okay, so calcium has been, diuretics has to be given, dialysis can be done. Okay, very good, very good, very good answers. So now see this and tell me the electrolyte abnormalities present.
Hypokalemia and chloremia.
Hypokalemia, hypochloremia, and
Calcium.
Metabolic alkalosis.
Metabolic alkalosis.
Very good.
Hypocalcemia, hypokalemia.
Very good.
Raised urea.
Raised urea. So what do you think? Raised urea, normal creatinine, hypo.
Diuretic induced. Diuretic induced.
Okay, and three etiologies. Any other cause?
Vomiting, GI loss.
Okay. Hypochloremic alkalosis, very good. Vomiting and Urea is raised. Urea is raised. So these are the findings: hypokalemia, calcemia, chloremia. So generally, it is why there is refractory in hypokalemia. We need to replace magnesium. Everyone knows this, right? For refractory hypokalemia, we need to supplement magnesium. If the magnesium levels are not normal, the potassium levels will not be corrected. Why? But what is the cause? Why we need to give magnesium for refractory hypokalemia? Anyone? So your magnesium is the cofactor, okay, for your sodium potassium ATPase renal tubules, okay. So that is why if there is low magnesium, there will be potassium loss. Unless you correct the magnesium, there will be no potassium retention, okay. So the other causes, as I told, inadequate intake, alcoholism, diuretics, very good answer. Drugs like amphotericin, cisplatin can cause this. Redistribution, again, that is because of insulin and Hungry-Bound syndrome. These all can cause the third picture. Now this one,
Hyponatremia, hyperkalemia, acidosis, hypoglycemia,
very good.
mixed edema, coma.
Okay.
RTA, renal tuberous acidosis.
Yes.
Aldosterone deficiency.
Any other cause?
Adrenal.
Very good. Very good.
Adrenal
Yes.
insufficiency.
Very good. Excellent answers. Okay. So hypoadrenalism, there is increased ADH. Okay. So that is water loss. So body tries to preserve water. So there is increased ADH secretion. So that is the cause of hyponatremia, and reduced aldosterone. That aldosterone causes the hyperkalemia. Okay. Very good. Excellent answer. Now this one. Everything is normal except your
Disproportionate raised in urea as compared to creatinine.
very good. So high urea creatinine ratio. What are the causes?
Causes are GI bleed, dehydration, high protein diet,
Very good. Excellent answer.
diuretic induced.
Excellent answers. Okay. And another is a steroid. Okay. Dehydration, high protein, GI bleed, steroid therapy. Very good. Very good. So now this one.
Hyperkalemia, hyperphosphatemia with high LDH.
Yes.
IST hemolysis or rhabdomyolysis.
Okay. Very good. What are the calcium levels in rhabdomyolysis and hemolysis?
It should be hypo.
Okay. So that is present.
Hyperkalemia and hyperphosphatemia is present.
Very good. Okay. So the answer is here. Rhabdomyolysis. Okay. Very good. Hypocalcemia is the clinching. So now
Total protein is elevated.
yes.
Total protein in urea is elevated.
Yes. And
Hypercalcemia,
Calcium is elevated.
raised albumin and urea, multiple myeloma.
Multiple myeloma.
Yeah, very good answer.
Short.
Your total protein is raised, albumin is on the lower side of the near normal level, so there is high globulin. Okay, so this is multiple myeloma. Excellent. So now this is very easy one.
High anion gap metabolic acidosis.
Yes.
High anion gap metabolic acidosis.
Excellent. So the causes.
Cat mud piles. Salicylate toxicity, alcoholism, then
decay.
So there is hypocalcemia also. Would you like to add anything? Along with mud piles, there is hypocalcemia with severe metabolic acidosis.
carbon monoxide poisoning.
Carbon monoxide poisoning. CO2 levels.
Hyperventilation.
Hyperventilation is because of the acidosis.
Ethylene glycol, toluene.
Yes, very good, very good. And
Pancreas.
we discussed in the previous question another differential. Rhabdomyolysis, and what was the other answer in the previous question?
Tumor lysis.
Yes, very good. So in tumor lysis there is hypocalcemia.
Mm-hmm.
Yeah, so tumor lysis syndrome can also present with such kind of ABGs. Okay. So pancreatitis also there is hypocalcemia, tumor lysis, rhabdomyolysis, HI, your mud piles. Okay, very good answers. Now
Lactic acidosis.
yes, cause
Sepsis, hypoxia, hypotension.
but along with lactate another finding is there.
Glucose is low.
Yeah, which cases hypoglycemia and lactic acidosis.
Acute liver failure.
Very good, excellent. And
ALF.
yes, ALF and
So sepsis and infection may also cause both.
yeah, may cause. Okay. And
Metformin toxicity.
which toxicity? Metformin for lactic acidosis. Okay. And when will the lactate increase? Cause of lactate increase?
Seizure due to hypoglycemia.
Yes, very good. Seizures, very good, very good. Another
Low lactic clearance and liver failure.
that is liver failure. One, liver failure, seizures, and alcohol intoxication. Okay. Okay. Metabolic acidosis, low glucose, high lactates, alcohol intoxication. Okay. Very good. Excellent answers. So 64-year-old woman is brought to casualty in a confused state. This is the finding. So what diagnosis? PCO2 is high, glucose is low, creatine kinase is high, cholesterol is high. We read this today. "64-year-old woman, confused, PCO2 is high, glucose is low,
Thyroid.
Creatine, yes.
Thyrotoxicosis.
Yes. Excellent. Mixed hemochroma. Whoever told excellent answer. Okay. 64-year-old, confused state, PCO2 is high, hypoventilation. Okay. Glucose is low, creatine kinase is mildly elevated, high cholesterol, mixed hemochroma. Excellent. Then previously well 40-year-old man suffered gunshot injuries to his abdomen, multiple valve perforations which required surgical repair. He is slow to win off the ventilator. He is currently on TPN with the following formulation. What is this? Why is he unable to get wind of?
Hyperalimentation.
Hypertension. Very good. Very good answer. Very good. Okay. So overfeeding. 53-year-old alcoholic is admitted to hospital. Here we are giving actually 3,000 calories. So that is abnormally high. Okay. Okay. Our target should be
25 to 30 kilocalories per kg.
yeah. So that is around 1,500 to 800 calories. 1,800 calories. Okay. Okay. So whatever excess calories are getting, that will get converted to fat. Okay. So that conversion has a very high respiratory quotient. Okay. Okay. So that is why there is the high CO2 production. Okay. So that is why there is difficult to win off the ventilator. Very good. Excellent answer. So 53-year-old alcoholic admitted to hospital after an alcoholic binge. 1 day history of chest pain, vomiting, and shortness of breath. What is the diagnosis? This is the pleural fluid analysis. Okay. There was chest
Borave syndrome.
Yes, Borave syndrome. Excellent answer. Borave, why not? What other cause? Another similar thing can cause your left-sided pleural effusion. Alcoholic, vomiting, shortness of breath.
Pancreatitis.
Pancreatitis.
What does differentiate pancreatitis from Borave syndromes?
Amylase levels.
Will be high in both.
Lipase.
No, from here only. Here the clinching in this data given, there is a clinching factor which says it is Borave and not
gut content.
Yeast plus.
Yeast.
Yes, Yeast plus. Very good. Yeast plus is the clinching point for upper GI. Okay, rather than directly from pancreas. Very good. Very good. So how to diagnose? Gastrographin study. Okay. So patient underwent a therapeutic procedure in the ICU, and this was the lab values. What was the cause of this? Everything has fallen down. Protein, albumin, globulin, antithrombin, protein C, cholinesterase, calcium levels.
Plasmapheresis. Plasmapheresis.
Very good, very good. Plasmapheresis. Okay, perfect answer. So plasmapheresis, ionized calcium because of the citrate, there is low calcium. So 45-year-old man with GBS is admitted to ICU. On day 4, he is having the following reports. What is the cause?
Post IVIG induced
Yes.
protein, high protein. Post IVIG.
Post IVIG, excellent. IVIG therapy that is causing pseudo hyponatremia. Okay.
And high protein.
And high protein. Very good. IVIG, excellent answer. So previously fit 48-year-old patient was admitted with head injury to the ICU following an MVA motor vehicle accident. 72 hours after admission, he was having this. Okay, head injury. 72 after admission. This is finding. So what can be causes?
CSW.
Yes, very good. CAD and
Cerebral salt wasting.
cerebral salt building. Excellent. And another differential if you are using hypotonic solutions. Okay. So how to differentiate CAD and cerebral salt wasting?
Volume status.
Volume status. Very good. Very good. So this one easy. Skull base fracture.
CSF rhinorrhea.
CSF rhinorrhea.
How do you confirm?
Cysternography. MR cysternography.
Direct MR. No, it's a biochemical test. Your answer is correct, but why go for such high-end investigation? Any biochemical?
Beta transferase.
Yes. Beta 2 transferrin. Okay, very good. Correct answer. Then again, 35-year-old admitted to ICU with head and chest injury after MVA, motor vehicle accident, significant ICP raise, large diuresis. So why the polyuria?
Diabetes insipidus. DI.
Why not DI? What?
Mannitol induced.
Excellent, excellent answer. Correct. Who told? What is the finding here that goes against DI?
High urine osmolality. It should be low.
Very good. Yes, high urine osmolality goes against DI. Otherwise, it could have been a DI. Okay. So this is your mannitol infusion. Okay. So what is the calculated? How do you know this is mannitol?
Raised
Calculated.
ICP probably. And
Yes.
serum osmolality 320, more than 320 is achieved.
How do we know this is mannitol?
2 into sodium glucose divided by 18 and urea divided by 2.8.
Yes, very good. So calculate, or otherwise, as another easy thing is as everything is in millimoles per liter, so it will be 2 into sodium plus glucose plus urea. Okay, since it is in millimoles per liter. Okay, direct addition, no division. Okay, so that comes out to
Yes,
be
sir.
42 into 2 is 288. Okay, 288 plus urea 5.6 to 93.6, then glucose 6.8, so 300. Okay, but our serum osmolality measured is
327.
327. So that is the gap, osmolar gap, right?
Gap.
Osmolar gap is more than 20. So that is because of the presence of active solute such as alcohol or mannitol in the blood. So here it is mannitol because of the raised ICP. Okay. Okay, because the osmolar gap is more than 820, it is mannitol. So the formula for calculating, so differential is DI and cerebral salt wasting, but in DI your urine osmolality will be low and sodium will be high. So 28-year-old man with head injury, day 3. So what are the abnormalities present here?
Raised ICP, alkalemia.
Yes.
Alkalemia. And respiratory alkalosis with raised ICP.
Low respiratory alkalosis.
And low
hyperventilation.
blood saturation.
Okay. So high ICP, low cerebral blood pressure, jugular desaturation, hypocapnia, respiratory alkalosis. So for your low is jugular desaturation, what you have to do? check the accuracy of the result by co-oximetry, check the ABG, correct your low PO2, your maybe there is hypoperfusion, that can be the cause, correct your MAP, check hemoglobin, low hemoglobin can also cause low jugular desaturation. Okay. Now 36-year-old woman who has been in hospital for 10 days after an LSCS now develops weakness of face, arms and legs. GCS is 15, pupil dilated and fixed, tone reduced, reflexes diminished, sensory examination is normal. What do you think is the cause?
Guillain-Barré syndrome.
Okay, very good. Anything else? What goes against GBS here?
Pupils fixed and
Yes. What is going against GBS here?
dilated and fixed pupils.
That is also possible.
What happens in the CSF finding of GBS?
Ascending paralysis.
Albumino.
Albuminocytological dissociation.
Here is the protein high.
No.
No. So GBS is excluded. Could have been myasthenia, but your pupil is going, pupillary finding, pupillary filter is going against myasthenia, right? Okay. So what can cause? Post LSCS. Post LSCS. What can happen? Poorly maintained OT.
Tetanus.
Unhygienic instruments.
Meningitis.
No. GCS is 15. Sensory is normal. Tone, muscle, tone. Infected instruments.
Tetanus.
Somewhat similar.
Botulism. Wound botulism.
Yes, very good. Excellent answer. Okay. Wound botulism. Okay. Very good. All the differentials are discussed. Very good. Now 60-year-old man with alcoholic cirrhosis is diagnosed with bacterial endocarditis. Okay. So what is the coagulopathy present here?
High PT.
Yes, high PT.
High INR rest, everything's no.
Yes. So why? What is the cause?
Liver cirrhosis. Synthetic function affected.
Okay, and other causes? What is this HS time? What goes against this normal HS time goes against liver cirrhosis. Okay. HS is derived from a snake venom actually.
Sepsis induced coagulopathy.
Which induced?
Sepsis induced coagulopathy.
Endocarditis is vegetation.
Patient might be on anticoagulant.
Vitamin K antagonist.
Yes. Very good, very good, very good. Right.
Or endocarditis.
Okay. Normal TCT and normal HS time. TCT is your thrombin clotting time. Okay, and HS time is that from snake venom that is done to see the presence if it is liver or it is a external agent. Okay, so it is vitamin K antagonist. Okay.
Warfarin toxicity.
Very good. Okay, so these are the differentials: vitamin K deficiency, oral anticoagulant, liver disease, and DIC. Okay. So now 85-year-old woman presents with ruptured esophagus and empyema. Jejunostomy feeding tube is instituted. Similar, only the exist time is prolonged. So this one is which you told in the previous question.
Liver failure.
Liver.
Yeah. Okay. Very good. Okay, that is secondary to sepsis. Okay. So 54-year-old man returns from theatre post CABG and is bleeding briskly into the chest drains. So how do you correct this man's coagulation profile?
Cryoprecipitate.
Protamine.
Only APTT is elevated, probably heparin-induced protamine.
Okay, what goes against that?
Low fibrinogen.
Patient in DIC, hypofibrinogenemia, thrombocytopenia, raised APTT.
Yes, yes, yes. Okay. Why not? This is why this is not heparin, because your thrombin clotting time is normal. Okay, TCT is normal. So that is why this will not be heparin. Okay. So what is the cause?
CABG. Coronary bypass.
So what happens in bypass that can cause this? It's a bit difficult. Okay. Hemodilution. Okay. Coagulation factor deficiency because of your hemodilution. Okay. Dilutional coagulopathy. Okay. So 55-year-old woman presents for lobectomy because of carcinoma. Her coagulation profile is this. So what is the cause?
APLA.
Very good. Excellent answer. Whoever has given. Excellent answer. Why?
Sir, isolated APTT is increased. And
Very good. And what is
mixing
it
studies.
mixing? What does that indicate? Anyone can explain?
Sir, mixing with the normal patient's plasma after
Yes.
mixing.
Yes. So if the APTT gets corrected,
it is due to the vitamin factor deficiency. But if it is not corrected, it is due to inhibitors.
very good. Excellent. So we are mixing normal plasma, mixing study. We are using normal plasma to the current patient plasma. So your normal plasma will be having your factors. So if normal is, that means the current plasma has shortage of factors. So the normal plasma corrected the APTT. But after mixing of normal plasma also it remains raised. That means something is inhibiting the factors. That is why the normal plasma also could not help in reducing the APTT. The APTT was prolonged even after mixing. So that is because of any external drug present which is inhibiting the factors. Okay. Very good answer. But why lupus? Again, why not LMWH, the factor inhibiting factor?
TCT, no.
Okay, TCT is normal. That is why. Okay. So for knowing LMWH, we have to see anti-10A activity. Okay. So it is lupus. You have to go for anti-cardiolipin and display. Son of 28-year-old man presents with constitutional symptoms and acute tonsillitis. He undergoes tonsillectomy complicated by post-operative bleeding, necessitating reintubation. So this is the picture. Patient has INR is high, platelet is low, TLC is high, APTT is raised, fibrinogen is low, D-dimer is high. Cystocytes are present, or rods present, promyelocytes. So what is the diagnosis?
DIC.
DIC, very good. And the disease?
APML.
APML, very good. So APML with DIC. Okay, PT raised, APTT raised, low platelets, cystocytes, and D-dimer raised. Now this one.
Hemophilia.
Anything other answer?
Snake
Platelet
bite.
dysfunction, von Willebrand disease.
Very good. Von Willebrand disease. Okay, not hemophilia. Von Willebrand disease. Okay, platelet count is normal, but your APTT is raised. Okay, and bleeding time is raised. So von Willebrand or
Sir, Glanzmann thrombocytopenia.
okay. Okay. Others are your patient of AMI on aspirin and heparin or post bypass or post dialysis. Okay. Now, 25-year-old man with known HIV infections presents to emergency department with headache, obtundation, and fever. Petechiae are noted over his trunk. He proceeds to a generalized seizure. Cystocytes are present in peripheral smear count. LDH is raised.
TTP.
SPLT raised. Yes, yes, very good, very good.
Anemia. TTP.
TTP. Okay. Platelets are low, 25,000 only. INN is normal, APTD is normal, fibrinogen is normal, everything is normal. And what is the pentad?
Micronephrotic hemolytic anemia, thrombocytopenia.
Yes.
Fever, neurological abnormality, and renal dysfunction.
Okay. Excellent. So here we have renal dysfunction, creatinine is raised, urea is raised, fever is present, obtundation, headache obtundation is present, generalized seizure, all are present. So this is TTP. Very good. Excellent answer. Now, only your bleeding time is prolonged. Rest all everything is normal.
Snake bite.
No, no. In snake bite there will be DSC features. Your others will get decreased.
Platelet
Platelet is
disorders.
normal, but your APT and PT and these all are normal, no? So cannot be snake bite.
Hemophilia.
Only bleeding time, platelet normals. Everything is normal. Factors are normal. Everything is normal. So something present is normal, but that is not working.
Functional platelet disorders.
Yes.
Functional platelet disorders.
Yes, very good. Functional platelet disorders, like it is seen, dysfunctional platelets are seen in
CKD.
Glanzmann.
very good. CKD. Okay, uremia. Uremia causes low quality of platelets. And
Celiac-Higashi syndrome.
okay, that's a long shot. Okay. Others, easier causes. Okay. NSAIDs, beta-lactams, bypass. Okay. Beta-lactams basically your penicillin, ticagrelor, carbamazepine, uremia. Remember this point. Desmopressin 0.3 mics per kg improves the quality of the platelets in uremia. Although its effect is short-lived, around 4 to 6 hours, but desmopressin can increase the quality of the platelets. Okay, desmopressin. Okay. 2-year-old child is floppy and unresponsive with these factors. What is the local diagnosis?
Vascular toxic snake bite.
Yes. Vascular toxic. Excellent. Okay. Now 35-year-old woman. So in vascular toxic snake bite, platelet is normal, but your FPT, PT all deranged, fibrin is deranged. Okay. So mostly this is a snake bite. Perforated appendix, MODS, patient is gradually recovering. Full blood count and iron studies. Are this. So what is the likely cause of her anemia?
Iron deficiency, TSAT low.
Okay, iron is low. But what is going against iron deficiency anemia?
Ferritin normal.
Normal ferritin.
Yes, that is going against iron deficiency anemia. There is microcytosis, but there is not microchromia. And ferritin is normal, so not iron deficiency anemia. What?
Anemia
So
of
sepsis
chronic
induced.
disease.
Yes.
Anemia of chronic disease.
Yes, yes. Very good, very good. It is anemia of chronic disease. Okay. 18-year-old male presents with abdominal pain, dizziness 24 hours after a football match. He has a diffusely tender abdomen. This is his blood count. What is the most likely cause?
Blood injury to the
Plenectomy.
blood promoter aorta.
Hemoperitoneum.
Yeah, hemoperitoneum. Very good. So acute blood loss. Okay. So your retic count is high. Whenever there is a case of anemia, what all do you send to evaluate anemia? To evaluate anemia, what all do you send?
IPF and retic count.
Iron profile, retic count. What else should you send?
Peripheral smear.
Very good, peripheral smear. Another thing for diagnosing hemolysis?
LDH.
LDH. Okay, so whenever a case of anemia presents before you, the cause is not known. CKD patients, okay, we know it is because of CKD and all. Otherwise, if any anemia generally presents, unexplained anemia, always send a peripheral smear comment, LDH and retic count. Okay, and iron profile. Very good, very good. So the patient, that same patient, undergoes a laparotomy for his hemoperitoneum. On post-operative day 5, these are his counts and findings.
Trauma-induced coagulopathy, hyperfibrinogenemia is there.
Yes, that is acute phase response. Okay. So because of the acute phase response, your fibrinogenemia is there. Now, why thrombocytosis? Why the platelet counts are high?
Sepsis.
Sepsis, generally platelet counts become low, no? Where are the platelets destroyed in our body?
Spleen.
Yeah. So what surgery would you have undergone?
Splenectomy.
Yes, very good, very good, excellent. So most probably he has undergone a splenectomy. That was the cause of his hemoperitoneum, and because of the splenectomy, there is thrombocytosis. Okay, very good, excellent answer. The Havel-Jolly bodies, that is also a diagnostic. Okay, leukocytosis, target cell, thrombocytosis, and Havel-Jolly bodies. They are post-parental status indicators. Now, 25-year-old woman is admitted to ICU with 60% surface burns and treated along standard lines. Day 3 is normotensive, well perfused, core temperature 30 degree, urine output and everything is normal. She is conscious. This is her picture. What is the cause?
Neutropenia, sepsis. Fever with neutropenia.
Yes.
Febrile neutropenia. Likely underlying cause.
So this is neutropenia. So what is the cause of neutropenia?
Fungal sepsis.
Because of burns itself? Or
Yeah, because of burn itself. Very good. Very good. One cause burn. Another cause?
Because kidneys expose new onset sepsis. Sepsis induced leukopenia.
Okay, sepsis induced bone marrow. Okay. But your platelets are normal. Hemoglobin is normal. Okay. Another, it is hypothesized that the silver sulfide as an ointment that is applied for the burn patient that can cause this picture. Okay. So this is actually self-limiting. Generally takes 4 to 5 days. Okay. So it improves. So 16-year-old asthmaticus, status asthmaticus, upper respiratory infection. And this is a full blood count. Okay, so there is lymphopenia. Why?
Steroid induced.
Very good. Excellent.
Viral infection.
Very good. Very good answer. Viral infection that causes the precipitated the status asthmaticus. That can have lymphopenia. Okay, very good. Very good answer. Other causes are your sepsis, SLE, TB, brucellosis, radiation, HIV, and all those. Okay. Stress response can also cause lymphopenia. Very good answer. So 25-year-old male with type 1 diabetes mellitus with severe diabetic ketoacidosis, epigastric pain, and patient is vomiting. Is alert, not shock, no shock is present, non-tender abdomen. So neutrophils so left shift, and this is the finding. Okay. So hemoglobin is high.
Dehydration induced policy.
Dehydration induced policy.
Dehydration. Excellent answer. Dehydration. Okay. Other causes, decay itself. Okay. Sepsis, severe shock can also cause stress. And if the TLC are more than 50,000, it can be termed as liposomal reaction. Okay. But here the TLC was 28,000. A 38-year-old woman with rheumatic valvular disease with mitral valve prosthesis, prosthetic valve presents with breathlessness and a new onset pansystolic murmur. So what is the likely cause
Infective endocarditis.
of this picture? Hemoglobin.
Infective endocarditis.
Can be. And
Stuck valve.
Low haptoglobin going towards hemolysis. High retic towards
yes,
hemolysis.
exactly. High retic count, so definitely hemolysis.
Negative,
So because of hemolysis, because of mechanical hemolysis, because of the valve. Okay. Very good answer. Okay. And what is the point of giving direct Coombs test negative and Hinge body is 0%? What do they? Yes.
It's not autoimmune.
Not autoimmune. And Hinge bodies? Hinge bodies for drug induced. Okay.
Okay.
Hinge body is for drug induced. If there is Hinge bodies, this is because of drug induced hemolysis. So direct hemostasis is negative, so it rules out autoimmune hemolysis. So this is mechanical hemolysis because of this stuck valve. Very good. Now 28-year-old patient presents to the emergency department in coma. He has rapid deep respiration. Okay, CT brain is normal, CSF is normal. There is severe metabolic acidosis. PCO2 is low. 24 hours later, he is noted to have fixed dilated pupils. So what does it say?
Glucose elevator. HHS.
Ethynyl glycol toxicity.
Okay.
Alcohol dissociation or HHS. Glucose is high, osmolality is high.
Fixed dilated pupils. What does that tell?
pH is good.
Alcohol intoxication. Which alcohol?
Methanol.
Yes, it's correct.
Osmolality.
Methanol. Okay, methanol toxicity. Okay, very good. So because of the raised anion gap, high anion gap, it is alcohol intoxication definitely, and because fixed dilated pupil, it is methanol. And someone told ethylene glycol, no?
Yes, sir.
What goes against ethylene glycol here?
Normal ionized calcium.
Very good, excellent. Okay, so that goes against ethylene glycol. Okay, so this is methanol poisoning. Very good. So previously, where 28-year-old man collapsed in lounge, whatever in airport, he had seizures in the ambulance en route to the hospital. So GCS is 3, hyperthermia, heart rate 140, BP 210 by 120, pupil 8 mm sluggishly reactive, perforated nasal septum plus. ECG shows ST depression, T-wave inversion, urea on the higher side, creatine on the higher side, creatinine kinase is 14,000, markedly raised. So likely diagnosis?
Cocaine abuse.
Cocaine abuse, excellent answer. Okay, very good. And how do you diagnose cocaine?
Hypertension, yeah, nasal.
Tachycardia. Young male.
Diagnostic.
And no, nasal.
Diagnostic.
ECG changes ways of constriction.
Those are all
features.
clinical findings. No problem. What is the diagnostic test? Means test.
Urine toxicologist.
Urine toxicologist. Very good. Very good. Okay. So differentials here: your pheochromocytoma, thyroid storm, amphetamine toxicity. So urinary screen clinches the diagnosis. Very good answers. So 70-year-old woman with long-standing stable rheumatoid arthritis was admitted to ICU with breathlessness. So these are the investigations. Hemoglobin is low, TLC is low, platelet is low, MCV is high. So what is the cause of breathlessness in this patient?
Vitamin B12 deficiency leading to pansite 2.
Pancytopenia, very good.
Vitamin B12 deficiency.
Yes, very good answer. That can be a cause. And tell me why the patient is breathless.
Due to anemia.
Anemia
Anemia.
leading to failure.
Effusion is a possibility. Long-term rheumatoid arthritis effusion.
Long-term rheumatoid, ILD, very good, excellent. These are the two causes that could have caused SOB in this patient. Excellent answer. And the likely cause of blood picture, one
Megaloblastic anemia.
Megaloblastic anemia and
Methotrexate induced.
methotrexate. Excellent answer. Very good. Very good. It is methotrexate. Okay. So how will you treat this methotrexate poisoning?
Folinic acid.
Very good. Folinic acid antidote and
Leuco.
faster
Of methotrexate. Transfuse.
transfuse what?
Leucovorin.
Leucovorin. That is what, no? Folinic acid.
PRBC transfusion.
Okay, PRBC transfusion and
B2
What? How
resistance.
to remove the methotrexate from the body?
Dialysis.
Will it get dialyzed?
Urinary alkalization.
Urine alkalination. Very good. Okay. Urine alkalination. Alkaline diuresis. Okay. Very good. Now, 34-year-old woman was admitted to ICU after having been found unconscious at home by his mother. History of head injury and post-traumatic epilepsy. So now GCS is 3. Patient is hypothermic, no neck stiffness, pupil mid-sized and reactive. Tense bullous lesions were found over his finger, elbows, and ankles. CT normal, CSF normal. Suggested diagnosis.
Drug reaction due to antiepileptics.
Yes, which antiepileptic? Which antiepileptic will cause low GCS, hypothermia, pupil mid-size and reactive, low GCS? Okay, methotrexate can be dialyzed. Okay.
Phenytoin.
Phenytoin, no.
Benzodiazepine.
Not benzodiazepine.
Lamotrigine.
No. Old age antibiotic.
Valproate.
No. We induce coma.
Phenobarbital.
Yeah, phenobarbital. Okay, barbiturates. So this is barbiturate overdose. Okay. So treatment is your ABCD, lavage, and dialysis. Okay. So very good. So now coming to last topic today. I know you already are stressed out and completely exhausted. Just simple things I will say about burn. Okay. Are you all ready for it?
Yes, sir.
10 minutes. We'll get it done in 10 minutes. Okay.
Okay, sir.
So burn severity is classification is determined severity is determined by patient's age, the percentage of body surface area burned, depth of burn, type of burn, and if any specific parts are involved. Okay, so this is how it is burn severity is classified. So it is severe burns if in children less than 10-year-old or elderly more than 50-year-old if it is greater than 10% of total body surface area. It is severe burn. In adults, it is greater than 20%. Greater than 5% full thickness is a severe burn. Any electric burn, high voltage is a severe burn. Burn to face, eyes, ears, joints or genitalia is also a severe burn. Okay. Now the pathophysiology, what happens is in burn, so inflammatory and vascular mediators such as histamine, prostaglandin.
Everyone please mute. Everyone please mute.
Everyone please mute your mics. Just 5 minutes, then we'll start. Okay, so your vasoactive mediator, histamine releases there, prostaglandin, cytokines are released. They cause systemic capillary leak, intravascular fluid loss, and there is large volume of fluid shifts. So that is the cause of shock. Okay, so this generally over the first 24 hours it takes place, peaking around 6 to 8 hours after the burn injury. There is also because of this third switch loss, there is decreased cardiac output and increased vascular resistance because of the shock. Now, marked hypovolemia and hypoperfusion. So this is called the burn shock. Management. So immediately stop the burning process. Remove the burning or hot items from skin contact. Take a history. Okay. Allergies, medications, past medical history, last oral intake, very important, and events of the injury. So again, management first, airway, breathing, circulation. Okay, depending on that, focus on the airway, looking for any burns, presence of soot, means any black particles inside the mouth. Okay, to know if there is any inhalational injuries present. If your airway is compromised, there is a risk of compromise of airway. Okay, so inhalation, that is what we have to focus. Okay, so then bleeding or circulation problems by looking for any bleeding because of vascular rupture, and check the blood pressure, heart rate, and pulses to know Okay, and so resuscitation has to be immediate. So secondary survey with a complete physical examination has to be done. Okay, evaluate and treat the burns. They are part of the secondary survey. Now we have to calculate the total body surface area of the burn, percent of burn injury, and then the depth. Okay, so burns of more than 20 to 25%, we have to give aggressive IV fluid. Okay, in case of the burn injury is calculated by rule of 9. Okay, and in case of pediatrics, unmute and
Lens.
So Lund-Browder's chart.
very good, very good. Okay, so for pediatric we use that, and for rule of 9 we generally use for adults. Okay, so there are various formula of calculating the fluid needed. Brooks formula, Weston formula, rule of 10. What we generally use is Parkland formula. So in Parkland formula it has to be 4 into so 4 into percent of burn surface area into weight of the patient. This much of fluid has to be given in first 24 hours. So this is just to get an idea how much of fluid is given. Actual fluid has to be resuscitated depending on the clinical status of the patient. Patient GCS, patient heart rate, blood pressure, urine output. The urine output should be your target. Okay, this much fluid we have to give. This is just a calculation to know how much of fluid should be given. But actually, we should target a urine output of 0.5 mg, 0.5 ml per kg body weight. Okay, accordingly you have to give the fluids. So 1/2 of this fluid calculated by Parkland formula given over the first 8 hours. Rest half is given over the 16 hours. Okay, it's just a guideline. So vital signs, mental status, capillary refill, urine output should be monitored, and the fluid decision should be taken accordingly. How much of fluid is to be given? In children less than 30 kg, we should target from 0.5 to 1 ml per kg per hour. Now ancillary treatments. So nasogastric tube placement. So as most patients will have in ILS, Foley has to be put to monitor output. Pain control has to be given. Generally, we have to give IV analgesics. Oral may not be sufficient. Okay, and tetanus prophylaxis has to be given. Flame burn, we have to suspect inhalational injury. Then surgery is generally not needed. Extensive debridement and application of topical microbial films are basically not needed. And then we need emergent hysterectomy surgery that is needed when there is a chances of compartment syndrome. So it relieves the constricting effect of the full thickness burn. So what happens? How can we suspect a compartment burn? In which areas, like in your leaves?
Dr. Shwetesmani, please mute yourself. Dr. Shwetesmani.
Is it mute now? I'm unable to see. That is why.
Now she has muted, sir.
Yeah. So emergent hysterectomy is to be done if you're suspecting compartment syndrome, like in case of limbs, or in case of abdomen compartment syndrome. In chest areas, if patient is unable to breathe properly, adequate ventilation may be impossible because of your SCR formation. So then only emergent hysterectomy has to be done. It has to be done bedside. Since there is complete damage of the nerve roots, there is no need of anesthesia. Simply you have to incise till the fat. Okay, hysterectomy is done till the fat pops out. Okay, so that is what hysterectomy is, to relieve the tissues. So complications, that can be breathing problems, bone and joint problems, contractures, dangerously low body temperature because of fluid loss and all. Infection and sepsis is the most dreaded complication in case of burns. And low blood volume, scarring, tetanus. So anemia secondary to full thickness burns greater than 10% body surface area is common anemia. Electrical burns may result in your compartment syndrome or abdomyolysis. Blood clotting in the veins in the legs, DVT, causes in around 6 to 25% with extensive burns. So hypermetabolic state may persist for years after a major burn and may decrease bone density and muscle mass. So these are the different various complications. Keloids may form after a burn. Post-traumatic stress disorder, scarring, disturbance in body image, social stigma, and contractures. Okay, these are the various complications. Okay, so that is all for today. Thank you so much for participating. So you all may now log out. Good night for today. And again, same thing. Any advice or any recommendations for us, please write in the WhatsApp group. So you will get the video recordings. Already our sir has told, our HOD, you will get the video recordings. If you need slides, PPT, there is some, I think, extra. You have to pay for that, I think. Okay. So
Today's data interpretation is very excellent, sir. Thank you.
You all answered very well. You all answered very, very well. Excellent answers. Okay.
Thank you, sir. Thank you.
Thank you, sir. Thank you, sir.
Excellent participation. So it encourages us when participating so nicely. Okay. Good night for today. See you next week. So if any recommendations, if you are doing anything wrong or you want anything better or anything, you may please write in the group. We will make our PPTs or whatever accordingly. Okay. So good night for today. Bye.
Bye.